some specialized CT protocol or something else. So, but anyway, once CT was done, it can help. And as I said, the follow-up, the thyroglobulin level is limited, TSH normal, and surprisingly, without any suggesting level of evidence, they said every 1-3 year ultrasound for 5 to 8 years, they said if no evidence of disease, they said they can stop follow-up. So this suggests a very interesting point compared with the active surveillance, because active surveillance is lifelong. But if we do early surgery, we can just follow 5 or 8 years without medication. But that's a very interesting point. So now we know that active surveillance is a very viable option, benefits of avoiding surgery and preserving thyroid function, while challenges of requiring meticulous monitoring and patient collaboration is very crucial. And now, they emphasize active surveillance as a recommendation. Previous guideline is just a consideration, now recommendation. Once I said again, with a clear protocol. And over 1 centimeter active surveillance was not recommended, but now, in the very limited situation, we can consider. Over 2 centimeter PTC, it is not recommended. So, how? And whom for active surveillance? Still, it is a difficult question, but maybe young age is not appropriate because of lifetime nature. And also, we don't have an effective indicator of disease progressions. Longer the follow-up, worse the cost effectiveness, and increase the chance of loss of follow-up. And lifelong surveillance versus active surveillance stopping. For example, one of my patients are 80 years old, having 12 years of active surveillance, still disease stable. Should I stop or lifelong surveillance another 10 years until she dies? We don't have answer yet. Finally, I would like to talk about a little about thermal ablations. Now it seems very promising. Complete ablation may be possible because in other cancer we have done. And oncological safety is short-termly okay, but still we don't have long-term efficacy. Also, there is a problem of cost effectiveness and ethical concerns. So, Korean Thyroid Associations raised some key questions like this. The first, RFA an effective treatment? Maybe yes, because already proven in other cancers, short-termly. And is RFA safe and tolerable? I think also it is yes, because already it is done for many cases in benign disease. And what is the essential requirement for the operating facility, and also how we can educate for team? Yes, it is possible. But still 3 remaining questions, so I would like to introduce drafted KTA recommendations. First, indications. We recommend for the from 6 millimeter to 1 centimeter PTMC only, because our recommendation do not recommend fine needle biopsy itself for smaller cancer. And Bethesda 6 is indication, and once BRAF mutated, Bethesda 5 can't be the indication. Location itself is not a matter, because if it is subcapsular or paratracheal, we can do with the technique of hydrodissection, injection cell lines to move the tumors to the safer locations. And T1B can be considered if the patient do not have surgical conditions. And we think in these cases, it's not appropriate. And the evaluations, before and after, we recommend the same evaluation as surgery, because many doctors doing thermal local ablations it's just a procedure, and they never follow, they never evaluate. So I cannot tell the entire things, but we recommend the exact same evaluation before and after radiofrequency, and especially ultrasound, just immediate ultrasound for evaluation of procedure success. I think it is important. Well, still we have some problems because a long-term cost, efficacy, safety are still under investigation. Yes. Yeah, this is last slide, sorry. Yeah. And there is a chance of abusing. So we may push the patient to the procedures, and also education and team building problem. And also there are cultural context because this society, this country, these peoples are ready to the local treatment. So I think we can do and we should do is a little bit different. So we should keep in this mind in managing PTMC. Thanks for the attention.
Thank you, Professor.
Thank you, Professor. Now we are going to move on with the next speaker, Dr. Shakir Bahzad. He will talk about the role of molecular study in undetermined FNAC thyroid. Dr. Shakir Bahzad is a specialist in clinical as well as molecular genetics. He is also board-certified clinical and anatomical pathologist, and he is currently working at the Kuwait Medical Genetics Center and in the pathology lab at Kuwait Cancer Control Center. Welcome, Dr. Shakir.
Thank you so much. Let me just check. That's, yeah, this works. And how do you just press this one? No? Yeah? Okay. So, good afternoon, everyone. So my name is Shakir Bahzad, and I'm a clinical and molecular geneticist, and I divide my time between the medical genetic center and the cancer control center. And so today I'm going to offer you a solution to an annoying age-old problem, which is the undetermined significance nodules. So let's just go there. So the solution is simple. So it's just a simple molecular test that actually avoids unnecessary surgeries and spare the patients as well as surgeons and the healthcare system lots of grief. And the test itself is called thyroid print. But first, let's address the problem. So the problem here is, as in the common scenario, you have a thyroid nodule, FNA is done under the microscope. You have different options here. So first, if it's cancer, which is around 8 to 10%, they go for surgery. So that's a no-brainer. If it's benign, which is around 2/3 of them, you just stop and this follow-up. However, you have this around 20 to 25% cases who are categorized as Bethesda 3 or 4. These are undetermined. These are neither benign or malignant. What the cytopathologist actually says when they put this Bethesda 3 and 4 is, we have no idea what it is. So these, historically, they have a risk of cancer of about 25%, but the older guidelines, they push for surgery, and they end up with a lot of unnecessary surgeries. So the solution is, when you have the nodule FNA, and you have your benign and the cancer, the undetermined ones, they go for thyroid print, which is a simple test I'm going to talk about in a minute. And you have two possibilities. Either it's, where is it? Yeah, either it's benign, which in our molecular jargon we would call low expression. So the negative predictive value of this test, in this case, it's around 96%, which is actually pretty great. Which means that there is only 4% chance that this is malignant if it comes back as low expression. And in these cases, you can avoid surgery, and we just recommend follow-up. However, if it's what we call high expression, which is, sorry, oops, go back. So if it's high expression, there is also a good positive predictive value of around 67%. So it's 67% chance that this is actually malignant, but there is the chance of around 33% that is benign, but these are can go for surgery. I mean, can go safely for surgery. So now, let's just start with some of the guidelines. So the Bethesda guidelines evolved over the years to go from just morphology to include other immunohistochemistry and special stains, and then molecular testing. So, so the current ones, they go for Bethesda 3 and 4, which is ATP of endodermal significance, and 4, which is the follicular neoplasm. Again, which means we have no idea this is malignant or not. They recommend now, before surgery, molecular testing. So, and then international guidelines, the American, the European ones. This is just to show how they evolved. And it's historically, before that, most of them, in these cases, in Bethesda 3 and 4, they push for surgery in most cases. However, the recent guidelines in the past few years, they strongly recommend molecular testing before the surgery. And well, with a small exception, if these Bethesda 3 and 4 nodules are not suitable for active surveillance, so especially if it's a large size, if it's symptomatic, if there are malignant signs on radiology, they go for surgery without no need for molecular testing. They just go for surgery. Otherwise, if it's truly undetermined and we have no idea this is malignant or not, molecular testing is the answer. So what do we do? It's very simple. So with the FNA, the product is inserted into or put into our buffer solution, and then we do a qPCR, quantitative PCR, of 10 specific genes, and then we determine if the test is high expression or low expression. So let's go into a little bit more details. So there are a plethora of evidence in the literature, whether for that specific test, the thyroid print, or molecular testing in thyroid in general, starting about a decade ago with the biomarker discovery of these genes, and then clinical validation and clinical utility in those cases, and the inclusion in international guidelines. So what are these genes? What do we do? So we look at the expression of genes. These are not mutations. We are looking at how these genes express themselves. So if you sequence them, you're not going to find any mutation in them. We check the expression by determining the amount of RNA coming out out of these genes. And these genes are specifically chosen for their role in malignant transformation, epithelial mesenchymal transition, proliferation, and the inflammatory microenvironment. So if you put the two together, the clinical practice and the lab together, this is what you come out of. So you have the thyroid, you have the nodule, you have the test itself. Under the microscope, you see this is undetermined significance. And there are two ways of doing this. So there is an ideal way, which is some hospitals, they have the setting of, they have a bedside microscope at the FNA clinic, and this is probably the best way of doing this. So the first go, they look under the microscope. The patient's still there. They look under the microscope. They determine if this is Bethesda 3 or 4. If it is Bethesda 3 or 4, they go back. The second go, they put it in the buffer, and they send it to the lab. So this is ideal, but not all hospitals have this setting. So I believe Jabir has it, and Adan probably, but the others, they don't. So the other option is, they look at it, and the cytopathologists look at it, they determine this is Bethesda 3 and 4, and then the patient actually goes home. The ultrasound is reviewed again, or actually repeated, and then if it's determined to be uncertain significance, they go for another FNA, and this FNA will will take our sample for molecular testing. And this should be at least 6 weeks apart, just to avoid false positives, because these genes, with the manipulation, with the trauma of the needle, sometimes they upregulate themselves and falsely come back as positive. So we need that safety time. So a little bit technical stuff. So this is the cartridge of the test. It's an automated, simple, closed system. So it's this machine. You cannot use anything else on it. Okay. So this is these are just snapshots from the instruction manual. So this is how it's actually taken by the cytopathologist, and this is our lab part. So this is probably the most crucial QC point. So this is what we're looking for. So once the sample itself goes into the buffer solution, it changes color. This is not blood. This is not a bloody sample. This is just a reaction between the sample itself with the solution into the buffer, and it should be dark maroon burgundy. So this is what we're looking for, and when I look at it this way, this is probably going to work. However, if it's very light, just yellowish, clear or yellowish, this is most likely it's not going to work. This is how an inadequate sample looks like. Just for the sample collection, probably if we have any cytopathologist here. The needle we use, usually the bigger ones, so 21, the smallest one you can use is 25. Smaller than this, it gives invalid test results. Well, if it's hypervascularized, you can go for the smaller ones. If it's highly calcified, you go for larger pores. And you try to avoid highly vascularized areas as much as possible. Sometimes it's not, but sometimes, well, if you can, you do. And if the nodule has a dominant cystic component, we recommend that when you go in, you take the colloid and you discard it, and then you go back again for a proper sample. So transferring the sample should be gentle. So take the needle, just rest it on the inner wall of the tube, and gently push it in for it to mix with the solution and start changing color. And just to avoid bubbles, because bubbles and qPCR, they don't work together. And just respect the full line. This is what happens in the lab itself. It's a very simple procedure. There's not a lot of labor in it. Actually, anyone can do it. It takes like around less than 10 minutes tops. And it's centrifuged, diluted, and then put in the machine. So the good thing about this system is it's small, it fits everywhere, and the turnaround time is very short. It's once we do that, the 10 minutes hands-on, and then less than 3 hours, you have your results. So what's in it? It looks at 12 genes. 2 of them are just reference genes. These are our controls. And 5 of them are involved in tumor inflammatory microenvironment. And the other 5 are tumor epithelial genes. And again, we see the expression of those, not mutations. So it's like 3 simple steps. So just prepare it prepare it in the cartridge. Just put the cartridge in, and then you get your results. So this is what you get out of it. So there are 3 possibilities when you get the results. So we have valid and valid test. So this is when the reference genes, the 2 reference genes, they pass the QC, and also the target genes. So in this case, this test is valid. So not determined when you have the references pass, but the target genes fails. If the reference fails, this is invalid. So this is not readable. So usually we repeat those. So this is how it looks like. So when the test is valid, you have either high or low. So high expression, low expression. And again, if it's low expression, there is a 96% chance that this is not malignant, this is benign, and the patient can avoid surgery, but just put on follow-up. And if it's high, there is a 67% chance that this is malignant, and surgery is recommended in these cases. So our experience so far, we've used 16 cases. We're trying to validate the test in our lab, and we got 8 with results and 8 without. So we got 6 lows, and we got 2 highs, and I hope they went for surgery. 1 was undetermined, even with repeating the test, and 7 were invalid. So this high number is because we tried every case. So most of the cases here were actually all of them. The 7 invalid ones were the clear or light yellow color. So in a clinical setting, we usually discard those. We reject those samples. We don't do them. But I did them just out of curiosity, because just to see what happens. Do they work or not? And they did not. Okay, so lastly, so these are the comparison. These are the ones commercially available similar test for the thyroid, and this is our test here. And if you can focus on these 2 columns, the negative predictive value and the positive one, they are very, very similar to each other. So we chose the last one because we already have the machine. It's much cheaper than the others. So this cost us something, the cartridge cost us something like 75 to 100 KD. The others, actually, like the ThyroSeq, for example, it's $4,000. And it gives you the same results with a turnaround time of like 3 weeks. Actually, I'm done. Thank you.
Thank you, Dr. Shaker.
Thank you for this talk about molecular testing. Our next talk will be about molecular imaging in thyroid cancer beyond radioactive iodine, which will be presented by Dr. Alia. Dr. Alia, she completed her medical education at Kuwait University and obtained her board certification from Kuwait Institute of Medical Specialization in Nuclear Medicine. Currently, she is a nuclear medicine specialist at Jabir Ahmed Center for Molecular Imaging. She had also completed her positron emission mammography training at Bahia Hospital in Cairo, and recently obtained her PET-CT fellowship from University of Zurich. She has research contribution with multiple novel PET tracers at high index publications. She currently holds the head of scientific committee at Kuwait Board of Nuclear Medicine. The floor is yours, Dr. Ali.
So thank you for the nice introduction. Today I'll be talking about molecular imaging and differentiated thyroid cancer, mainly beyond conventional active radioiodine. So the functional imaging of thyroid cancer with radioactive iodine was the breakthrough that launched the field of nuclear medicine. As in this area of precision medicine continue to shape a practice, ongoing development of next generation, and promise improve specificity, lower sensitivity, and improve the specificity and lower the dosimetry for the patient, with a broader application in disease characterized the prognosis and treatment monitoring and shaping of treatment. In this image in front of you, there is an illustration of multiple level of molecular imaging aiming to image the microenvironment of the thyroid cancer through starting with the cell surface up to the transporter and deep inside the molecular imaging. Mainly, I'll be focusing on the new, relatively new PET tracers rather than the conventional radio tracer used now, iodine-131 and iodine-123, starting with the sodium supporters tracers. So iodide concentration inside the cell is the first step in the production of thyroid hormones, NIS considered as an integral basolateral membrane activity transporter that transport the iodide against its against its electrochemical ingredient. Differentiated thyroid cancer is known to have a lower NIS expression, though it can be detected by the sensitive radioactive iodine. And we have two new tracers, the iodine 124, which is a PET tracer rather than the SPECT tracer iodine 124, 123, and 131, sorry. Also, we have the tetrafluoroborate, TFB, which is the newest one. Iodine 124 usually require the same preparation as the one for the 131 and 23. However, it can be imaged 24-hour post-injection of the patient. It has a superior sensitivity and better spider resolution than more than the iodine 131, and provide an accurate measurement of iodine uptake using quantification of the PET. It improved detection of a small lymph node and local recurrence, and enable patient-specific dosimetry, as we can see in the coming slides. So, in this study, 69 patients were examined, and they compared the retrospectively, and they compared the iodine 124 finding to the 131 scintigraphy finding, and they found a concordance of 87% in the cases. However, iodine 124 was able to detect 12% more nodal involvement and 4% more distance metastases that were skipped by iodine 131. Also, the Van Nostrand group found a similar finding. They studied the local recurrence mainly and lymph node and found 50% more foci seen on iodine 124 and not seen on 131. This study was aimed to measure the dosimetry based on the PET quantification, and they found by performing the dosimetry retrospectively calculation for 131 therapy based on iodine 124 PET-CT, they evaluated that any lesion that receive more than 70% gray, 75% gray, they have a good response, while those who received less than 75 show minimal response or no response at all. The fluorine 18 tetrafluoroborate is another tracer that depends on NIS. However, it doesn't go through organification, similar to pertechnetate, basically. It can predict the radioiodine therapy responsiveness, and considered to be a cheaper option or alternative to iodine 124 in assessing metastasis and local recurrence or redifferentiation. In comparing these two tracers, we found that the iodine 124 remained the gold standard regarding for dosimetry calculation and therapy assessment, basically. However, they both have a good or excellent redifferentiation therapy monitoring, good resolution and sensitivity. TFB, however, had much less radiation received to the patient, and the availability is much more available and easier to produce comparing to iodine 124, which have high cost and require specialized centers. This study of tetrafluoroborate was meant to assess, this meta-analysis was meant to assess the 5 publications. 2 of them were talking about dosimetry, and the 3 assess the tracer efficiency, basically. So in this study, in this meta-analysis, it appeared that TFB has a safe, favorable biodistribution with higher sensitivity comparing to iodine 123 and 131. Radiation exposure was significantly lower than other radiotracer. However, when disease heterogeneity are in doubt, a combination of TFB with the FDG is recommended. This is an example of heterogeneous disease, as you can see on the green arrows. all of the lesions that are detected by TFP and iodine equally and not detected on FDG, while the red arrows representing what dedifferentiated tumor only monitored or only detected on FDG. This is another example showing a false positive low mediastinal mass seen on iodine 131 that proven by biopsy to be benign in origin. And we can also notice that on the FDG scan, we have a mediastinal lymph node metastasis that was not detected on either of the iodine or the TFP. Now, when we come to FDG remain you cannot consider FDG as a first line in well-differentiated tumor, but it's essential when there is a loss of iodine avidity. And what we have is the flip-flop phenomena. Basically, a well-differentiated tumor will have even low expression of NIS and will show iodine avidity. However, it will show low FDG avidity. While dedifferentiated tumor will have almost absent or diminished NIS and will be seen on FDG scan. Here are the ATA recommendation in 2025. And as we can see that the FDG remain essential when there is a high or rising in thyroglobulin and negative iodine 131 scan, whole body scan. Also, we have to take in consideration that whenever thyroglobulin level is more than 10 nanogram per ml, it gives us a better result seen on FDG. So, in this meta-analysis, they found that the RH stimulation detected significantly higher number of lesions compared with non-stimulated PET tracer, even with FDG. And FDG has a promising role in a response assessment of the refractory DTC patient receiving TKI, so it can be considered in patients who are taking TKI for therapy monitoring. Now we come for the new shining star in the field of nuclear medicine, the FABI. FABI can be linked to different radionuclide, gallium or fluorine and lutetium, which provide, when we link it with the lutetium, it provides us an option for theranostic or therapy response. It's a group of radiotracer that target FAB, which is a cell surface protein highly expressed on a cancer-associated fibroblast. So this study was aimed to study the gallium fibroblasts in compared to FDG in a DTC patient, and they found that the FABI was even better than FDG, and if not comparable in detecting disease recurrence and lymph node metastasis. However, when we consider that the patient is having distance metastasis in lung and bone, FDG remains superior to FAB scan. This is another study that assesses fluorinated FABI and almost give the same result. This is one example of the studied group. We can see on the A images that the patient having higher uptake and lower on FDG, and when they it was studied histopathologically and found that it was related to the disease itself. So FABI at the end give us a better SUV, better high tissue to background ratio. So we were able to detect local recurrence, especially when there is a fibrosis in the area over on the surgical bed. PSMA is mainly used, sorry for PSMA is mainly used to detect prostate cancer. However, it can measure the neovascular of the tumor itself. And whenever we found focal uptake in thyroid scan, at the thyroid scan or thyroid bed, it is a possibility that the patient is having a cancer. However, still, FDG remain better than FDG in studies comparing PSMA to FDG, and it can play as a role as complementary. In other studies, they found that some lesions express PSMA, other express FDG, and doesn't express PSMA. Okay, so now we come for the somatostatin receptor, which is dotatate, and in this study also comparing FDG to the role of dotatate in a patient with DTC, They found that dotatate is superior in assessing loco-regional and lymph node metastasis than FDG. However, FDG were superior in metastasis disease. Also the same concept, flip-flop phenomena. Some lesions are expressed on dotatate and other are expressed on the FDG. It's interesting to note that whenever there is a negative iodine-131 whole body scintigraphy, FDG is superior. However, when the lesions are seen on iodine-131 scans, basically, DTC, the dotatate, and FDG performed similar or concordance in cases of DTCs. Lutetium-177 dotatate therapy. The evidence remain based on a few case reports and the serial studies. The efficiency is around 30 to 40% in most of the cases. The last radiotracer is the fluoroascorbic acid, which show a safe tracer with a low dosimetry and easier preparation. However, it have a promising role in lutetium and assessing lymph node and local recurrence. Studies remain still under studies. Okay, and these are my references. Thank you.
Thank you, Dr. Ali. I kindly ask our speakers to stay till the end of the discussion session, please.
Now we are going to move to the next session, which will be presented by Dr. Yasser Ad-Darazi. It's about cervical node disease in T1, T2, and 0 papillary thyroids. CA, is it still controversial? Dr. Yasser Ad-Darazi is a consultant general surgeon and associate professor of surgery, specialist in endocrine, breast, and upper GI surgery, and he is graduated from Arabian Gulf University, Medical College, Arab Board in General Surgery, and Fellowship in Endocrine Breast Surgery at Royal Northshire Hospital in Sydney.
First, I would like to start my presentation thanking Dr. Ali Al-Musawi, my friend from a long time, and all the organizers. Shukran. So my topic today will be prophylactic central neck dissection in T1 and T2 nodes negative papillary thyroid cancer. Is it still controversial? So can we move this next? I'm sorry. So as we know that papillary thyroid cancer is the commonest endocrine tumor, and it has a very excellent prognosis with a 90% 10-year survival. Now, we know that central lymph node metastasis can occur in 40 to 60% of papillary thyroid cancer, and this frequently occult recurrence is not seen preoperatively by imaging or clinically by palpation. So prophylactic neck dissection is like the removal of level 6 and also the upper level 7. And these patients, they don't have a clinical or radiological evidence of nodes disease. So there are significant heterogeneity across the American Thyroid Association and the ESMO and the Chinese and also the NSCC practice recommendation. As we know, this is a slide about the central neck dissection, which is basically the boundaries, the hyoid bone superiorly and inferiorly, we have the amniotic vein, and also medially, the two carotid artery. So we know there's a lot of structure here passing. One of the important are the recurrent nerve and also the parathyroid. So the first study here is a Chinese study. It's a retrospective study by Wu et al. 2025. The question in this study was, is prophylactic central dissection necessary for clinically node-negative papillary thyroid carcinoma? This study has a long follow-up of 10 years. It's been like patients were enrolled from 2011 to 2015. So they had like a total thyroidectomy patient. They have around 146 patients. The other arm was the total thyroidectomy with central dissection, and it was about 231. So all they have, nodes negative, they all have papillary thyroid cancer, and no radioactive ablation was used. So they found that there is occult lymph node metastases were identified in 82%, which is almost 35% in the central group, confirming high prevalence of microscopic disease despite negative preoperative imaging. The oncologic outcome of this study, there is no significant difference in the disease occurrence or overall survival between surgical approaches, questioning the therapeutic value of this prophylactic dissection. Now, the surgical morbidity, the complication was significantly elevated in the central dissection group. They have like hypoparathyroidism, about 38.5%, compared to the non-dissection, which is 24. And also, accidental finding of parathyroid in the specimen, about 6.5%. And also, the injury of the rectal nerve increase. So the clinical implication, routine prophylactic central neck dissection does not improve the oncological outcome in low-risk parathyroid, micropapillary thyroid cancer, but significantly increase the surgical morbidity and this supports the ATA 2025 recommendation. The second study, this is from PISA, Italian study. It's a randomized trial. And the question was the prophylactic central dissection in nodes negative papillary thyroid cancer, a 10-year randomized controlled trial. And we say in their study, they have 196 patients. The one who completed only the follow-up were 151. So they divide the total thyroidectomy patient, 70 patients, and the total thyroidectomy with central dissection, 81. And all received low-dose thyroid ablation. The primary endpoints in this study, there was no significant differences observed in disease survival and disease-free status, and also serum thyroglobulin, and the need of additional surgery or thyroid ablation, and also no difference in the long-term recurrence rates. So the surgical outcome, comparable complication profile, except more parathyroid. In their study, they found identified histology in the central neck dissection. So the conclusion was central neck dissection does not improve the oncological or surgical recurrence over extended follow-up in these patients. This is a very highly randomized clinical trial. Now, the third study is by Zahu, meta-analysis about hemothyroidectomy. And we can see that it's a meta-analysis of 7 studies, 6 were retrospective, 1 randomized clinical controlled trial. And they have the hemothyroidectomy about 1,042 patients, while the hemothyroidectomy with central dissection, 1,090 patients. And the focus was on low-risk nodes negative papillary thyroid cancer. So what they found that in the local recurrent, no significant difference in the recurrence rates. So the hemothyroidectomy only 4.75, while the hemothyroidectomy with the dissection was 3.5. So there's no improvement with prophylactic dissection based on analysis of 5 studies, which was not statistically significant. And the author conclude that prophylactic central neck dissection does not improve disease survival or reduce the recurrence rate in patients undergoing lobectomy for low-risk nodes negative papillary thyroid cancer. So, and the clinical implication was no clear justification for adding prophylactic central dissection to hemothyroidectomy in low-risk clinical setting. I have this also from Surgical Oncology Insight by Aran et al. 2000. It's like a narrative review, and key points in his study showed that prophylactic central neck dissection should not be performed routinely in nodes negative papillary thyroid cancer. But this should be offered to T3, T4 tumor, or tumor with aggressive histology or molecular marker like BRAF mutation, and also where surgical planning needs staging information. There was always risk of rectal nerve and hypocalcemia, especially and the author concludes that emphasize the risk stratified, compartment-based, surgeon-specific decision-making. The clinical application, this clinical application support the American Thyroid Association guides to observe central compartment unless high-risk feature exists. The final study was Yang et al. From also China. He compared the Chinese with the Western data. And the question of his study was, is there a difference between Western countries and China in central neck dissection outcome? طبعا they have a meta-analysis of 18 studies. They divide into two groups, total thyroidectomy, which is around 3,005 patients, and the total thyroidectomy with central dissection around 2,341. And the key finding was, in the Western data, they showed that there is decrease in local recurrent rates with the central dissection, 3.8 compared to 5.47. And also increased the temporary hypoparathyroidism, which was around 24.7. But there is no difference about the permanent complication. Now, the Chinese data, they show no significant local regional recurrence reduction. But there is higher rates of both temporary and permanent hypoparathyroidism. And the author concluded that the efficacy of central neck dissection varied by region, possibly due to surgical technique and also patient characteristic and pathology. Now, what are the arguments which support prophylactic central neck dissection? First, the occult metastasis detection. As we see that in Wu et al., he found around 35.3% patient has occult medicine. And also improving the staging accuracy by Yang et al. Study. Lower local regional recurrence by Yang et al. In his study. And he showed that it reduced like around 3.8, as I mentioned before. And also reduce the need for reoperation by Iran et al. Study. And also the lymph node ratio prognostic value also predicts the lateral neck recurrence. And this is according to American Thyroid Guidelines 2025. And also risk factor identification. T3, T4 tumors benefit more from central neck dissection, according to the American Thyroid Association guideline. Now, what are the points against prophylactic central neck dissection? There is no survival benefit, as Papini showed in his Italian study. No difference in the disease-free survival or recurrence rate over a 10-year. And also higher complication, the hypothyroidism, around 38.5 in Wu et al. Study, and higher permanent morbidity with increased recurrent laryngeal nerve and parathyroid in Zhou et al. Study. There is no local recurrence benefit in low-risk small tumors, especially if the tumor is less than 1 centimeter micropapillary, as Wu et al. Shown in his study. There is no disease-free survival improvement after hemothyroidectomy, with the meta-analysis by Zhou et al. And the higher rate of radioactive thyroid ablation, more frequent in central dissection patient, as Zhou et al. Showed, and also the ATA guidelines. Just to summarize, the American Thyroid Association recommend against routine central neck dissection in small, non-invasive papillary thyroid cancer with nodes negative. And this is very strong. Wu et al. In his study, there is no difference in the recurrence or survival or the temporary complication. Papini from Italy showed no oncological benefit and no difference in complication. Yang et al. 2023, he showed the Western data, they show decrease in local recurrence rates, where the Chinese, they didn't show that. Zhou et al. Showed no disease-free survival benefit in hemithyroidectomy patient. Hugh, which is like one of the authors of the American Thyroid Association, observation, he said observation is safe for most nodes negative patient. Wong et al. In his study, he said in every 31 patient we do central dissection, you can prevent only 1 recurrence. So the take-home message, do not perform central neck dissection routinely, especially if the tumor is small, T1, T2, or non-invasive univocal. But you have to consider it for big tumor, T3, T4, or when there is extrathyroidal extension, or there is high-risk feature, or where pathology guides adjuvant therapy. You should always weigh the risk and benefits, especially if you have an older patient with multiple comorbidities and also higher surgical risk. What is important is also the surgeon experience. The surgeon with high volume surgery, always different. In conclude, I would say in clinically nodes negative papillary thyroid cancer, prophylactic central dissection remains a selective tool. It is not a standard. Thank you.
Thank you, Dr. Yasser.
So our next speaker is Dr. Nawal Ataybi. Dr. Nawal, she's a graduate from Kuwait University School of Medicine in 2014. She completed her internship in Farwania Hospital and then completed internal medicine residency and endocrinology fellowship in Vancouver, Canada at University of British Columbia. She's currently working as endocrinologist at Jaber Hospital. Dr. Nawal is a Kuwait Board of Internal Medicine Assistant Program Director for Residence Affairs, and she is also a faculty member of Kuwait University, currently working as clinical tutor. Her talk today will be about the role of pre-thyroidectomy legal solution in Graves' disease and true risk of thyroid stop. The floor is yours, Dr. Nawal.
Thank you for the kind introduction, and I would like to start by thanking Dr. Ali and my surgical colleagues for the invitation. It's always a pleasure to present to our surgical colleagues. So today I'll be talking about the role of pre-thyroidectomy legal solution in patients with Graves' disease, especially those who have uncontrolled pre-thyroidectomy free T4. So before I dig deep into the topic, I would just like to tell you about a patient that we currently have admitted to Jaber Hospital, which shows us why this topic is important. So this is a 24-year-old female who recently was diagnosed with Graves' disease by my colleague, Dr. Ahmed Al-Kandiri, who will be presenting right after me. And he started her on numericazole, which is the first line for Graves' disease, or like antithyroid medications, and escalated her to the max dose, 20 milligram TDS, and the patient still has a very high free T4, more than 3 times the upper limit of normal, still symptomatic on the maximum dose. So now the question is, what do we do for this patient? The more definitive therapy will be for her is surgery, but the patient has uncontrolled free T4, so what do we do in this case? So why does this topic matter? Because Graves' disease is one of the most common causes of hyperthyroidism, and in these patients, the therapy is one of 3 things. In most patients, the first line is medical therapy, but what if the medical therapy either fails in controlling or having like a resistant Graves' disease, or if the patient develops a reaction to this medication, whether this is a granulocytosis, a severe allergic reaction, or hepatotoxicity, then we cannot send them for radioiodine if they have a high free T4, because then we have a higher risk of thyroid storm, so then we have to send them for surgery. In these patients, we know that they have a higher surgical risk complication post-operative or intraoperative. So let's start with some history. I like to give credit for people. So Dr. Henry Plummer, about 100 years ago, was the first one to suggest, okay, what about using Lugol's iodine or potassium iodide to decrease the vascularity of the thyroid or the friability of the tissue? And ever since then, there has been multiple studies investigating this thing. So let's dig into, before we dig into the evidence, let's talk just about why do we think Lugol's iodine decreased the vascularity and decreased the free T4 and free T3 pre-op. Because basically, this is the phenomenon called Wolff-Jacobs, where when the thyroid sees a huge amount of iodine coming, I like to explain it as the thyroid freezes and just like produces less free T4 and free T3 because of decreased organification. And also, along with the decreased vascularity that decreases the blood flow to the thyroid, that is another reason why the free T4 and free T3 synthesis decreases with this phenomena. Usually, if the thyroid is normal or healthy, it will escape this phenomena after about 7 to 10 days. So let's review the evidence. There is multiple research out there. I picked, let's say, the 6 most recent plus had good amount of patients. So this is a retrospective study that came out of a single center in Stockholm, Sweden, where they looked at 10 years, all the patients who went for thyroidectomy received Lugol's solution for persistently hyperthyroidism before surgery. And they looked at the free T4 and free T3, and there was significant reduction preoperative within 3 to 7 days, and I will be showing you the results here. So they looked at 2 time points. One of them is between day 2 to 5, and the other time point is about 5 to 9. And if you look at it here, I don't know if the pointer works. Okay, so the free T4 level, the free T3 level, and the heart rate, all of them dropped significantly after day 2, at the first time point, which is day 2 to day 5. This is another study. This is a meta-analysis that looked at 9 studies, including 510 patients, and found that the iodine significantly decreased the thyroid vascularity on ultrasound Doppler and decreased the blood loss during surgery. There was no significant difference in the thyroid volume or operative time, and there was no difference, or let's say significant difference in the surgical complications. I think the most of the studies will look at either safety or benefit, right? So in this study, there was some potential benefit, but there was no difference or risk on the patients. This is the largest data set we have that looked at the Sweden registry, and we know Sweden is really good at recording their patients. So they included 813 Graves patients who had thyroidectomy, about 33 patients who were found high risk and had uncontrolled hyperthyroidism. Those patients received Lugol's solution, and there was the only difference they found was actually that the patient who received Lugol's iodine had a slightly increased calcium requirement on day 1 post-op and on discharge. But when they looked 1 month post-discharge, there was no significant difference. Other than that, there was really no change in the surgical outcome in terms of laryngeal nerve damage or operative time or bleeding risk. There was no complications in the Lugol's iodine other than maybe requiring a bit more calcium. So it was thought to just confirm safety in these patients despite needing a bit of more calcium in the transient phase. Interestingly, the next study I'm showing is going to show the complete opposite. So in this prospective cohort of patients that happened in the States, they basically, I don't agree with the design, but this is what they did. So for 8 months, all the patients who went for total thyroidectomy for Graves' disease, they decided that they will not get potassium iodide. And then the 8 months following that, every single patient went for thyroidectomy for Graves' disease, did receive potassium iodide, and they did compare the results. So in these patients, 2 things were looked at that were significant. The need for calcium, like the transient hypoparathyroidism, was slightly less in the patient who received potassium iodide compared to the patient who did not receive. And there was slight statistical significance in the vascularity looked on the Doppler. This is I think, only RCT. There is another RCT that I'm showing that the result has not come out yet, but this is an RCT that was done for a small set of patients, 56 patients who were randomized to either receiving Lugol's solution versus no Lugol's for 7 days preoperative, and they looked at the preoperative TFT and Doppler ultrasound 8 days before the surgery and at the day of surgery. They looked at the primary outcome being intraoperative and postoperative volume blood loss, and the secondary outcome including the duration of the surgery, the TFT. There was significantly lower free T4 and free T3 levels, but other than that, there was not much significance in the operative time or complication. So most of the studies showing more or less the same evidence, at least for safety. So this is the last RCT that I said the results has not come out yet, although the trial concluded in 2022. There was an abstract that was discussed in the European Society meeting in 2023, showing that there was no clinical significance or statistical significance in the difference between the 2 groups. So what does the ATA and ACE guidelines recommend? Ideally speaking, all patients who are undergoing thyroidectomy for Graves' disease should have their free T4 controlled. But what if we cannot do so? Example, our patient who has resistant Graves on the maximum dose or developed a reaction to the medication. Then the ATA and the ACE joint guidelines, although it's being old, they do recommend giving some sort of potassium iodide or Lugol solution preoperative for 7 to 10 days. So who would benefit the most? Again, we're not talking about a patient with Graves' disease who wants to go for surgery because we need to decrease the antibody titer for their thyroid eye disease, or a patient who wants a definitive surgery, like a definitive therapy because she wants to get pregnant in the future, or whatever other reason, recurrent disease. We are talking about patients who are thyrotoxic preoperative because these carry the highest risk for all those surgery. These patients might benefit, again, as we presented, with decreased blood loss and decreased free T4 and free T level preoperatively. The limitations, so again, there is very few randomized controlled trials. In most of the trials I showed you, the number of patients is very little. In every single trial, mostly did not exceed 50 patients or so. So we need larger randomized controlled trial that compared the same regimen. So the problem with all of these trials, some of them tried potassium iodide, some of them tried Lugol solution. They come with different things that they looked at. So we need a more standardized randomized controlled trial to come up with a certain recommendation. So I just put a summary for you guys because I think it is very important to realize in Kuwait, the potassium iodide we have is a very dilute form of potassium iodide. So it is not the sort that is recommended in the guidelines. In the guidelines for preoperative Graves' disease, they recommend either Lugol solution, which combines potassium iodide with free iodine, or saturated potassium iodide, which is very highly concentrated. In Kuwait, we don't have any of these two. We have the 65 milligram in 1 ml. So if I just like organize it for you to kind of roughly understand, the patient will need to take 1 to 2 drops from the saturated potassium iodide to get about 100 milligram of potassium iodide. In our patients, we are giving them 1.5 ml to achieve the same dose. This is not the standard for Graves, but we are working with what we have here, and we don't even know if it does work in the same way of physiology or not. But so far, we had few cases that we have done with Dr. Salman in Jahra Hospital. I'm also sure that they're doing it in other hospitals as well with what we have here. The practical takeaway is that it is safe. The safety has been shown in all of the trials. The benefit is still questionable. Maybe some decreased blood loss and for sure reduction in free T4 and free T3. That was universal in all of the studies. So consider this in patients who have uncontrolled thyrotoxicosis who need to go for urgent surgery. And don't use it for more than 10 days, please, if you want to do so just within 7 days from the surgery. Thank you so much.
Thank you. Now, Dr. Ahmed Al-Kandari will present the last presentation of this session about the efficacy and the future of RFA in thyroid nodules. Dr. Ahmed is the head of endocrine unit in Jahra Hospital. He has the American and Canadian Board of Internal Medicine, Canadian Fellowship in Endocrinology, Canadian Fellowship in Endocrine Tumors with a special interest in thyroid nodules, cancer and thyroid interventions. I would like also to tell you that if you have any questions, you can scan the code which is on the screen in addition to the questions that we can receive by person.
Thank you very much, Dr. Dr. Ali, I asked Dr. Nawal to speak quickly, to finish quickly, and give me 3 extra minutes of her time. So she finished in 12 minutes, by the way. Okay. So thank you very much for the invitation and to ask me to talk about a non-surgical intervention in the endocrine surgery conference. That's something to commend by the surgeons. And in this talk, I'll try to convince you that RFA has a good evidence as for certain patient population for thyroid nodules and thyroid cancer. We'll talk briefly about it. So I have no conflicts of interest. And I have 2 disclaimers to make. The first disclaimer is that this is a general basic overview. RFA is a big topic. We usually go to conferences, spend 2 to 3 days only talking about thermal ablation and stuff. So in this 15 minutes, I'll just talk briefly about the basics and quickly go over the evidence. And I will only be talking about RFA. There are many modalities of thermal ablation. We'll only talk about RFA. So first of all, what is the drawbacks of surgery? And I have to be very careful not to criticize surgery too much in this audience. So we know that surgery is done under general anesthesia. There are risks of permanent recurrent laryngeal nerve injury, longer recovery time, lifelong hypothyroidism, and surgical scar, which is important in young females especially. For that reason, thermal ablation was tried 20 years ago for the thyroid in Korea by Dr. Baek in Asan Medical Center. And there are many thyroid ablation technologies. There are chemical ablation, ethanol, the one we use here. Tetracycline is used, but I've never used it myself. And thermal ablation, we use RFA, but there are other modalities such as laser, microwave, and HIFU, which is high-intensity focused ultrasound without even needing to pierce the skin. So just the principle of RFA is simple. There is an electrical current at the tip of the probe. This leads to ionic agitation. The ionic agitation will lead to frictional heat. Frictional heat will lead to tissue coagulation and tissue destruction. And that heat, there is a certain ideal temperature that we need to target. So we need to understand that, that the normal body temperature is 36 to 37. At 42 to 45 degrees, thermal injury to cell tissues start. At 46 degrees, there is irreversible damage if you keep the temperature for 60 minutes. At 50 to 52 Celsius, we're talking Celsius, there is an irreversible damage to the tissues if you leave the temperature and the heat for 5 to 6 minutes. And at 60 degrees, there is an instantaneous tissue damage. So that's the temperature we usually aim for, between 60 to 100. You all know that 100 Celsius is the boiling point of water, so we don't want to go beyond 100. So that's why you have to be very careful, and that's the difference between microwave and RFA. If the temperature exceeds 100 Celsius, that will lead to carbonization, and if there is carbonization, the body will not be able to absorb that carbonized tissue. So that's very important, and that's a safety measure we take into consideration in RFA. So that's the tip of the needle. Usually the heat is 2 to 3 millimeters in front of the probe, and that's how the operator stands. There is a generator, a water pump that cools the probe, and the operator sits at the head of the patient. And there is a screen with many things I will not go over today. And we usually use what we call the moving shot technique. So we usually, I don't know if this, sorry. How does the pointer work? Can I go back? Actually, I went too far. The small one? This one? Okay, and the pointer? This one? It's not working. Anyways, perfect. So the moving shot technique is we go plane by plane. So we insert, we got using the transismic approach, we ablate the first plane, second plane, third plane, and withdraw the needle. And that's how we do it. So we ablate this area, then we withdraw the needle, ablate that area, and then we go to the next line, and then until we ablate the whole plane. And then we go from inferior to superior or superior to inferior according to the operator comfort and planning. And of course, there are important structures in the neck we have to be careful about, so it comes with the risks. So you are a group of surgeons, I don't need to tell you about the anatomy, but you know that the recurrent laryngeal nerve runs medial to the thyroid. The left is predictable, the right is less predictable, so we call this the dangerous triangle in RFA or thermal ablation realm. And the C is a dangerous zone because, as you know, the right recurrent laryngeal nerve is variable, especially in the inferior parts because of the oblique course. So we're very careful there. So if I ablate here, I'm very close to the area where the recurrent laryngeal nerve there. So we take this into consideration, and I'll show you what we do. The vagus nerve also runs here. So there are, again, variable course of the vagus nerve. It can be medial, it can be lateral, it can be anterior, it can be posterior. So we have to localize it and identify it before the procedure. And that's just showing you the variation of recurrent laryngeal nerve. So there are two advanced techniques we use. One of the safety techniques called hydrodissection, Dr. Chung alluded to early, where we inject cold water. And there is a technique that we use to enhance the efficacy of the lesion. I'll go over them. So the hydrodissection simply is we inject cold water to shield the nodule and decrease risk of thermal injury. So this is a nodule. This is the carotid and where the vagus nerve runs, and this is the jugular vein. So we inject cold water here, and you see we separate the dangerous structures from the nodule, and we can ablate very comfortably there. In ultrasound, that's what you see. This is the cold water, so this is the nodule, and we can ablate with very comfortable setting and easily without needing to worry here. Now, for the recurrent laryngeal nerve, we have to do hydrodissection in the posterior part also to shield the recurrent laryngeal nerve. And the second technique is the artery first ablation, another technique that evolved recently. We target the feeding vessel for the nodule. So if we ablate it, the nodule will infarct before you even start the ablation. You can see this is a nodule where the feeding vessel was targeted. This is the nodule. You can see the black area, the nodule, half of the nodule infarcted before we even start the ablation, just by ablating the feeding vessel. So that increases your efficacy and your volume reduction later. So what are the indications for RFA? There are many indications, it's evolving. Benign thyroid nodules causing compressive or cosmetic concerns is the most important. Ideally, we want to have 1 to 2 nodules. More nodules, someone who has multinodular goiter, 4, 5 nodules, they are not ideal candidates, and surgery is better. Prior guidelines recommend a minimum diameter of 2 to 3 centimeters. That's a significant size that can cause symptoms, but that is changing because we know that the nodule location makes a difference. An isthmic nodule that is 1.5 centimeter can cause cosmetic concern more than a 2 or 3 centimeter lobar nodule. And the growing thyroid nodule, another indication, toxic nodules, recurrent thyroid cancer, well established, and papillary thyroid microcarcinoma. So let's discuss efficacy. We measure efficacy subjectively and objectively. Objectively, we measure the volume reduction rate by percentage. And if it was a toxic nodule, we look at the serum TSH. Remember that one of the main reasons why we do thyroid nodule ablation is to relieve symptoms. So we need to see if patient symptoms improve or not. So the subjective measure and symptom score, there are many, but we use symptom score, cosmetic score, there is ThyroPro 39, and there is SF36 that focus on the quality of life. So the cosmetic score is 4 grades, no palpable mass, 1, palpable but not visible 2, palpable and visible with swallowing 3, and easily visible 4. So we check this score before the ablation, and then we check it after the ablation. And same thing with symptom score. So the main symptom for the patient, let's say dysphagia, we measure it before and after on a scale of 0 to 10. Now, this is one of the earlier studies that looked at all the studies in the first 10 years of the ablation. Around 2015 or 2016 it was published. And we can look at most of, at the beginning, not a lot of studies performed the cosmetic and symptom score, but all those who performed, there is significant improvement in the symptom score before and after RFA, significant improvement in cosmetic score before and after RFA. And the most important thing is the volume reduction rate. So by what percentage did the nodule shrink after the ablation? We can look and see that most studies achieved at least 70% reduction. And usually 50% reduction in a nodule size is enough to improve the symptoms. That's another meta-analysis that was more recently published in 2020. And they looked at the long-term outcomes of benign thyroid nodules, and they found that the volume reduction rate at 12 months was at 36 months, 1.5 years, was almost 90%. So that's an impressive result that for sure will lead to improvement in symptoms. That led to many guidelines endorsing thyroid ablation. So Korean in the 2012, Italians in 2015, NICE in the UK in 2016. The Koreans also updated their guidelines in 2018, then the European in 2020, and there was a big international statement in 2021 that included the American head and neck surgery. Later also the ACE, American College of Endocrinology in 2022, and finally the American Thyroid Association in 2023 also published their statement and guidelines. And I just want to draw your attention that out of, 10 or 12 names, probably half of these authors are surgeons. Catherine Sinclair is a surgeon, Julia Newell, Stefano Spezia, Jennifer Coe. So half of the writing committee for these guidelines are actually surgeons, and probably there's only one endocrinologist there. So what about RFA versus surgery? That's one of the most important outcomes. There are not a lot of well-designed studies, probably 1 or 2 RCTs and a couple of meta-analyses. So I'll go over the one that are more important. Overall, RFA is associated with better quality of life and less complications. That's the theme of the studies. One meta-analysis that looked at 7 studies that included 1,300 patients found that thermal ablation in general was safer, associated with less hoarseness, hypothyroidism, post-operative pain, shorter hospital stay, better post-operative cosmetic effects, although in this study there was no statistical significance difference for symptoms improvement between the groups. Another RCT, probably one of the few RCTs we have in China that included 450 patients, found that this study focused mainly on the quality of life, found that fewer patients in the thyroidectomy group reported continued dysphagia, tracheal compression, and peculiar sensation in the throat, so surgery for that matter is better. But patients undergoing ablation experienced less pain, were able to return to work, social and athletic activities significantly earlier than the surgical group. And overall, there was more complication with surgery, including hypothyroidism, recurrent laryngeal nerve, hypopara. However, these data are only applicable if the operator, RFA operator or thermoablation operator, was a high-skilled operator. 94% of the patients who received ablation would recommend the treatment to a friend versus 32% who underwent thyroid surgery. So you surgeons are not doing a great job in promoting your surgery. And obviously, thyroid ablation takes a longer time to achieve the desired effects. Now, you can argue that most studies did not specify the skill or the volume of the surgeon. So an argument can raise by you that high volume, I'm telling you that the RFA or thermal ablation is associated with less complications, around 1.5% major complications. If the surgery was performed by the high volume surgeon, they have the exact same number, probably 1 to 2% risk of complication. My counter, I would say that's a fair argument, but my counter argument would be how many high volume surgeons are there? Studies in the United States show that only 10 to 20% of surgeries thyroid surgery done in the United States are performed by high volume surgeons. So the vast majority of thyroid surgeries are performed by non-high volume thyroid surgeons. And just if we look here in Kuwait, how many surgeons performs more than 30 surgery per year? I would say probably only a handful of surgeons. So if I'm a patient, I'm presented with 2 options, a thyroid surgery by low volume surgeon or an RFA or thermal ablation. Thermal ablation is much more safer than a thyroid surgery by low volume surgeon. So that's the option most patients are presented with in real life. Now, what about autonomously functioning thyroid nodule? Data are not as much as for benign nodules. Resolution of hyperthyroidism is less predictable than with surgery or RAI as we expected. And efficacy is more if the nodule size was less than 3 centimeters. One meta-analysis showed that 70% normalized after 12 months. I have to skip this. I will just go over one recent study that was published this year. And they looked at, this is a Latin American group. All of them are highly skilled operators. They've been performing RFA for many years. And they showed, they looked at 80 patients. The volume reduction rate was around 90% after 12 months, so very good result. And the rate of resolution of hyperthyroidism was 94%. So 94% resolved. That's an impressive result. And the size did not matter. What the message they delivered was, it's not the size of the nodule that matters, it's the skill of the operator. The more skilled you are, the more you'll be able to ablate the autonomously functioning nodule with efficiency. Because for these nodules, if you leave just a little area unablated, they will have a recurrence. I'm out of time. 1 minute?
1 minute.
Okay. I didn't even go over future. That's with the 3 minutes or without? Without. Okay. So future of RFA, there is a rapidly increasing role in thyroid cancer. Dr. Chung alluded to that. Recurrent residual thyroid cancer that's established, endorsed by the Korean guidelines. And for papillary microcarcinoma, there is an important role also. Parathyroid adenomas is being performed. A lot of people are doing it, not yet in the guidelines, but I'm sure it will be in the future. And for indeterminate thyroid nodules, it's also, there is a growing role. For micro-PTC, I will skip this. I'll just go over this recently published study around 3 or 4 years ago. They looked at 800 patients. This is the largest study we have. And they compared unifocal papillary microcarcinoma with lobectomy. 300 patients underwent lobectomy, 300 patients went ablation. Mean follow-up was 4 years. There was no significant difference between lobectomy and RFA in tumor progression, in lymph node metastasis, in recurrence, and in persistent lesion, and recurrent-free survival. And none of the patients who underwent RFA required a delayed surgery. So this is the best evidence we have. And RFA was associated with a lower complication rate. The recurrent, there is more evidence for recurrent thyroid cancer, especially if the patient was not a surgical candidate. I will stop here, I guess. I'll just go over one thing, sorry. This is very important. This is the appearance of a thyroid ablation after a nodule. So I have a patient who came to me, the ultrasonographer scared them and told them, this is thyroid cancer, you have to do a biopsy right away. So everyone should know that a nodule after ablation looks very suspicious. So you should ask the patient. If they underwent ablation, you cannot judge it anymore. Thank you very much.
Thank you, Dr. Ahmed. So I currently ask our dear speakers to join us at the podium for questions from the audience, and we have a couple of questions that came through scanning the QR code. So if you have time and you'd like to ask a question, but you are shy to ask it in person, so scan the barcode and submit your question, please, to our dear speakers.
The first question is to you.
So any question from the audience? Please, doctor. I have a speaker, microphone here for one of the questions. Just a 15 minutes question session, so if you do have any more questions, feel free after the end of the Q&A session. Yeah, please.
Thank you. Thank you very much for all the presentation. I will start with the last presentation by Dr. Kandari for the radio frequency. I just want to remind you that most of the studies in the last 2 decades, maybe when they start our radio frequency, is retrospective, and it was for 2 centimeter or less benign thyroid nodule. And most of these studies, of course, or most of these patients, it could be even controlled or managed by observation. So we don't have, until now, a solid evidence that radio frequency is safe, especially for cancer. It will have some indication for benign tumors, but also all of the study done by intervention radiologist or endocrine, they do not specify the complication if the patient has to go for open surgery. And I have seen several patients after radiofrequency, and the field was almost no anatomy. So this should be also taking consent from the patient about this complication. Thank you very much.
Thank you very much for your comment. Actually, I had a slide. If they have given me 1 or 2 minutes, I would have reached that slide. I commented on that issue. 2 issues we have to discuss is regarding follow-up. The first issue is the rate of regrowth, because after 3 to 5 years, 5 to 25% of nodules can regrow. So that's something we put in the consent. The other consideration is what about if we need a delayed surgery? Is there any poor surgical outcomes, meaning fibrosis? Would the surgeon have a difficult time in the operating field. Obviously, we don't have a lot of evidence, but in 2024, the only good study we have is from American group of Dr. Ralph Tofano. And they conducted a study. They looked at around 96 patients. 26 of them underwent RFA. 60 did not do RFA. And there was no poor surgical outcomes, no increased risk of complication between the two groups. That's the only one we have. So we have to take it with a grain of salt. We need more evidence. That point is valid. The other thing is regarding the first point, I agree. There is no long-term data regarding cancer follow-up. The longest follow-up we have in a study is 4 years for micro-PTC. And in that 4-year follow-up, there was no increased risk of recurrence in compared RFA to lobectomy. That's the only one we have. Please.
Yes. شكرا Dr. Ahmed. The same question is for Dr. Ahmed Kandri. My name is Yahya Al-Baddai. I come from Muscat. I'm ENT thyroid surgeon. So my question, it's not a question, it's a comment. Even high volume surgeons with the full experience of thyroidectomy, the complication rate is still significant. So high volume surgery does not mean that the surgeon has no complication. And the complication for thyroidectomy is still very significant. However, I'm a surgeon, so I don't usually recommend patients to go for RFA because going back to the surgical field, it's a nightmare. So any patient who go for RFA, I ask them not to come to see me. So that's my comments about this.
100%, I agree. As you said, there is always complication, and in general, complication with thermal ablation is lower than surgery. That's established. That's why, regarding the second point, going back to the operation theater, that's why in the Korean guidelines, they endorsed strongly like one of the strongest indication for RFA is recurrent thyroid cancer, residual thyroid cancer, because those patients will benefit the most. It's safer in that patient population than surgery. Of course, you have to look at the patient and what's the situation, but that's one of the strongest recommendations for RFA in thyroid cancer, residual or recurrent cancer.
Okay, thank you all speakers for the amazing talks. I want to shift from RFA. I'm going to move to the genetics with Dr. Shakir. Dr. Shakir, we know the three there are three available genetic testing: ThyroSeq, Afirma, Thyrogenix. The thyroid print, is that something new? And do you see in the next couple of years it will replace the commercially available, well-studied next generation sequencing or the available in the market?
Yes. Well, it really depends. So in our lab, we use NGS for almost everything. But for these cases, qPCR showed that it's actually much faster. And since it's a closed system, so it means that it's not labor intensive. So the hands-on time is like 10 minutes. And then within 3 hours, you have a result. And the other tests, the commercially available ones, these are not specifically for Bethesda 3 and 4. These are for thyroid in general. Speaking from from any type of malignancy. So these are big tests, and the workflow takes around 4 days for these tests, and they are not just for 3 and 4. So this test is simple, small, easy, and cheap for this category only. So these tests will continue. They're not going to stop. For us, we actually do, for malignant tumors, we do a comprehensive gene panel for those. So we have 161 genes, DNA, RNA, including MSI with it. And so this we do it for, proven cancer cases. But for those specific ones, just the 3 and 4, we do that test, and we can give you the results same day.
I presume it will get the BRAF and the TERT and those 10 genes.
No. They have nothing to do with BRAF. BRAF, KRAS, HRAS, NRAS, and RET, no. So this is actually what I try to emphasize, though these are expression genes, these are not mutation. We're not looking at mutations. So when you look at the mutations, you're talking about malignancy. So you're talking about BRAF, the 600E, or the HRAS, or the KRAS. These are not expression. These are tumor. Some of them are tumor suppressor, and some of them are oncogenes. And the oncogenes are just activated, and they produce more. We're not talking about those. We're talking about expression. So what we mean by expression is these genes, so they are not mutated, but upregulated. So they produce more than they should. And this is measured not by sequencing the gene, because it's not going to give me anything. It's measured by how many copies of RNA produced by that gene.
Okay, we'll take some questions which were sent through the code. There's a question to Dr. Nawal. It says, isn't it better to start with the Logos solution, a pre-thyroidectomy for patients, instead of waiting and increasing the medication dose?
You mean, so if the question means if instead of going up on the numercazole?
Yes.
No, numercazole or antithyroid medication for most patients remain the first line. And if I can control the patient on 20 milligram TDS, if this is the dose I have to control the patient, then this is the dose I'll keep the patient and not send the patient for surgery. Because with time, those patients will become controlled. The problem is if I'm on the max dose and I'm unable to control, then the definitive therapy with surgery will become pretty much the only option I have here. And then pre-surgical, I'll treat with potassium iodide or Lugols.
Okay, and there is another question to you, Dr. Nawal. It says that given that thyroid vascularity, has there been any discussions or evidence that using intraoperative perfusion imaging like ICG angiography to objectively measure how effective Logol is improving surgical planes and reduce bleeding?
So most of the studies that I have showed actually looked at only Doppler, not intraoperative imaging or vascular. They looked at the vascularity. It's mostly looked at the Doppler ultrasound, like vascularity on Doppler ultrasound the day of surgery, the morning of surgery, after receiving potassium iodide.
So another question was sent to Dr. Shakir. So this service, the thyroid print, in hospitals where there is no in-house molecular testing and it's not available, how patient will be referred to your service?
For now, the only molecular pathology is done at the cancer center. So that's the only place we have. And we have two places that they do genetic testing in general. This is the genetic center, which is mostly germline. These are for inherited genetic disorders. And somatic ones, these are done at the cancer center. This is where the molecular pathology lab is located and the fish lab is located. So for now, we receive those. So we do receive samples from all over Kuwait, actually, from all hospitals. So this thyroid print, we haven't launched it clinically yet. We are still validating we're trying to accumulate as many as possible. But again, if you have a case, please just give me a call, and then we can arrange for the test.
Okay, so another question is coming through the QR code to Dr. Alia. So in case that iodine 131 and FDG PET-CT could not identify the metastasis, what is your recommended next imaging step for these cases?
So basically you're talking in case of raised thyroglobulin. Why would you expect to have metastasis if the thyroglobulin is normal? In case it is iodine 131 scintigraphy negative, iodine FDG is usually the replacement, and usually it is enough to show the metastasis in the differentiated cancers. So
Apparently, the question is to arrange after negative iodine, a negative FDG PET-CT, which is your recommended next imaging step?
So usually we will follow up with the tumor marker, and if in case it's keep rising, we can repeat the FDG after the after thyroglobulin rise. Usually FDG is very sensitive when thyroglobulin is above 10, so that will be it.
To Dr. Ahmed Al-Kandari, do you have any limitations to do RFA in patients with bleeding tendencies?
Yes, so Dr. Chang, I think, alluded to some of the workup before the surgery, before the ablation. It's similar, not, I wouldn't say similar to surgery. We don't do full anesthesia workup because it's under local anesthesia, but part of the workup we do coagulation profiles and the platelets. So we have to make sure both of them are normal before performing it.
So your aim for the coagulation profile is what, INR?
Normal, usually normal INR and
Okay.
APTT, so INR less than 1.5.
Okay, and there is another question to you, Dr. Ahmed. For PTMC less than 1 centimeter treated by radiofrequency ablation, what is the strongest evidence we currently have for oncological non-inferiority compared to immediate surgery at 10 years?
That's a very specific question. So, so that should be, you should design that study, the person who asked the question, with a specific timing of 10 years. So, as I said, the longest study we have that I came across to is around 4 years, so 48 months. And in that study, there was no increased recurrence, and that was a comparison between ablation and lobectomy. There was no increased recurrence in that study. 4 years, the one I came across.
I have a question for the endocrinologist regarding a local solution or anti-thyroid medication before surgery. If the locals cause allergy or the patient cannot tolerate the locals, what the other option you have?
Excellent question, because the patient we had developed a mild allergic reaction. So for those who take the concentrated potassium iodide, the 1 to 2 drops, and the Lugol solution, you can dilute it in water, and this is actually the recommendation. So instead of taking the 1 to 2 drops directly by mouth, diluting it in water will decrease the adverse reaction, the allergic reaction. But for the one we have in Kuwait, it does not require dilution because it's already diluted. But let's say even that diluted amount the patient cannot take, then we will have to give them high-dose steroid to reduce the conversion. Most of them are already on maximum beta blocker. We can use cholestyramine, but I think the most important thing is discussion with the patient and the anesthesiologist. Having a skilled surgeon and a comfortable anesthesiologist should, they should be comfortable with all of these measures.
Did you try plasmapheresis?
We have not.
We have tried in one patient, of our patients. It was very effective.
But what are you targeting? The problem is, the question is, what are you worried about the most? Because if the goal is to reduce the biochemical numbers, then steroids and the other measures should reduce the free T4 and free T3, especially the free T3, which is the most active form, quite significantly. Plasmapheresis, I guess, is an option, but it comes with, there is a lot of potential complication.
We have tried it once in Canada for one patient who has very high liver enzymes. It works by washing out the antibodies. So if you wash out the antibodies, the trigger for the synthesis of thyroid hormone is down, so it lowers the thyroid hormone quickly.
I have a lot of questions. Sorry, I will give for Professor Kiwi. You mentioned several times in your presentation about ethical concept and consent for this patient who go microscopic BTC for surgery or radiofrequency. What do you mean? Why you insist on this ethical question?
Yes.
Thank you.
It's very important question, and I have my opinion, but it's not the answer. Please handle my opinion with caution. And in our country, radio frequency ablation is not covered by national insurance. So it means user fee is a little bit higher than the surgery or something like that. Sometimes some doctors may experience some kind of ethical problem to recommend the radio frequency or something like that. It is very common even in US also. So I would like to make a comment that any procedures, once proven, it has maybe a kind of option, not a definite answer. So have to know about everything, and we have to provide the exact information. Every procedure has pros and cons. Not active surveillance is the answer, not radio frequency is the answer, CLND is not an answer, not CLND not an answer. So that's what I want to.
Thank you so much. I'm sorry, we are out of time for questions. We are 2 minutes past the time allocated. So there is one message from the organizing committee for our dear speaker tomorrow. Please be present for the grand ceremony. And we'll be breaking here for 10 minutes break for a coffee break and then rejoin again. Thank you so much, our dear speakers, and thank you, audience, for all the input. Thank you so much.
Thank you so much. Can you please stay on the stage? We'll take a photo all together. The moderators with the speaker, please. Hello. Yeah, I would like to thank our both chairpersons, the moderators, Dr. Abdulrada Abbas and Dr. Fatma Khaja. Thank you very much. So please. Thank you. And Dr. Fatma Khaja. Thank you very much, Dr. Fatma. Thank you, Dr. Fatma. Thank you so much.
Can we start the session? So the moderator for this session is Dr. Mohammed Mursi. And Dr. Mohammed Mursi is one of our oldest consultant, general oncology, and the one that we really trust. And Dr. Rimshi is a consultant nuclear medicine. She's a physician in the nuclear medicine, and she's the one that she always attend our MDT meeting. So the floor is yours, both chairperson. We can start, please.
Thank you.
بسم الله الرحمن الرحيم. انت هنا، انت يا ابني، انت وهو. الو. قاعدوا. ركضوا. We'll start, inshallah, but before I start, I just give two minutes. I remember 30 years, I'm an old man. I remember 30 years ago, after presentation of some endocrinology procedures, I asked the official or the senior, do we need endocrine surgery here in Kuwait? And everybody laughed at me. What rubbish you are saying? Endocrine, what endocrine unit or endocrine surgery? Thank God I lived long to find my dream a reality now. And thanks to the enthusiastic guys here who established this system. This is one. Second thing, it is my sleeping time, by the way, so I will not allow anybody to extend his. The third thing is now thanks also to the organizing committee who gave me chance to co-chair a very important session, parathyroid pathology. Something was 30 years ago or 40 years ago when I was establishing my work or started my career. It was a nightmare to have parathyroid, and you have to collect all the guys and recruit all the facilities and so on to operate on the parathyroid gland. Again, thank God I lived long to implement this dream and co-share my friend to chair the session of the parathyroid gland. It seems the organizing committee gave me a chance, because I'm old, as a kind of indemnity reward before I retire. Thank you very much. Let us start. We have the first speaker here. I think he was properly introduced by in the previous session, but who were not before in the first session here, Dr.
Yasser.
Dr. Darazi, I'll read it from Dr. Yasser Darazi. He is a professor of, associate professor of surgery. He's from Bahrain, and he's a consultant. He will discuss a day case, parathyroidectomy. Is it a valid option? Dr. Yasser, please, tfaddal.
How we can work this? Sorry. First, I want to say something for the doctor. Old is gold. Introduction. My speak would be today, I just want to say that outpatient parathyroidectomy has been widely practiced since 2000. And this was enabled by better or advances in pre-op localization studies like SystemEB, ultrasound, and CT. And also by the advances in surgical technique, we have a lot of minimally invasive parathyroidectomy techniques. So the current trend, the majority of the procedure of nowadays for primary hyperparathyroidism are now performed as an outpatient basis with the same day discharge, and this mainly in high volume centers around the world. So the surgical approach and the day case feasibility. Not all parathyroidectomy can be done as a day case, so we have to know this first. So we have first the minimal invasive parathyroidectomy, where there is excision of a single gland, either radio-guided or focused dissection. It's an excellent choice for the case unit. And also the other procedure, the open procedure, where we do only unilateral neck exploration, where there is limited dissection of the tissue, it also can be considered as an outpatient. It's a good indication. Now, the problem is when you have the bilateral neck exploration for the 4 glands. Here, طبعاً, more dissection of the tissue, longer operative time. So there is a moderate risk, and also this lowers the day case rates for operation. So the advantage of minimally invasive parathyroidectomy, as we know, shorter time, operation, smaller incision, reduced tissue manipulation, and faster recovery. طبعاً the indication for minimally invasive, طبعاً usually we should have a positive preoperative localization study for this. And the second thing is very important, the absence of significant morbidities, especially طبعاً younger generation, older generation, maybe it's not a good option. So the first study by Flynn et al. 2011 in US, it's like a 10-year prospective study. It's a retrospective single-center study from 2000 to 2009. He had like 585 surgeries for primary hyperthyroidism. They divide them into outpatient clinic, around 43%, and inpatient, around 57%. And the key finding in the study was that the systemic complication is less with the outpatient, which is around 0.8, compared to the inpatient, 7%. And also, the local complication is less with the outpatient, around 6%, compared to 8%. The readmission rates for both outpatient and inpatient was not a difference between the two groups. So in his study, minimal invasive surgery was done in 94% as an outpatient group. He had like inpatient طبعاً was done for older patients and also those with higher complication rates. And the author concluded that outpatient parathyroidectomy is a safe procedure, even with moderate comorbidities. And this can reduce, طبعاً, very important, the cost and hospital utilization. And this study طبعاً support the day case parathyroidectomy for appropriately selected patient undergoing minimal invasive surgery. The other paper here is H. Wong et al. 2005 from US. It's a national database cohort study. And they have طبعاً the patient around 76,400 parathyroidectomy was done. And this was divided, the primary with the majority around 52,800. And then secondary or tertiary around 14,636. So at the beginning of the study, like in the early 2000s, the same-day discharge, the rate was 55%. And with the advances and with the time more, they reached up to 74%. They were done as an outpatient. The key finding, the same-day discharge, which was raising over time, as I said, from for primary hyperparathyroidism from 64 to 79. While in the other group, the secondary and tertiary hyperparathyroidism patient, طبعاً, the increase was smaller, only from 31 to 44%. طبعاً, inpatient had more comorbidities, seizure, dialysis, and other things. So he concluded that the case is more common in younger, healthier, and also with patients with primary hyperparathyroidism cases. And the author concluded that same-day parathyroidectomy is increasingly common and valid for low-risk patients, but require caution in complex hyperparathyroidism type. And the clinical application population data supports the expansion of data day case practice, but stratified by the surgical indication comorbidities. The other paper, Anisi et al. 2002-4, it's like a 20-year single-center experience. It's a retrospective cohort study from 2001 to 2022, and they have around 2,948 patients. طبعاً, they have a subset from 2013 to 2012, compared inpatient versus outpatient. And the key finding was that same-day surgery rate increases over time, same like the previous surgery. But there was no significant difference in the outcome, as like complication and success between the same day and the inpatient. And also, they mentioned that inpatients were more likely to be older, male, and ASA3 or on anticoagulant. And surgical طبعا success safety were similar across both cohorts. And the author concluded that same-day surgery is feasible and safe in a large experience center. طبعا patient selection, and very important, the surgeon experience is very crucial. And the clinical application, طبعا longitudinal evidence validates the case as a suitable model with stable outcome over decades. The fourth study here, Jank et al. 2002 from طبعا a single center in UK. They had around 257 parathyroidectomy for primary hyperparathyroidism. And the majority, around 240, were طبعا they were as an outpatient, 93%, compared to 17 who required admission. طبعا the complication, they have one patient who required IV calcium, and one had seroma, which was drained, and there was no mortality. So the key finding in the study is that the success rate as an outpatient is determined by the type of surgery. So if it was a single gland excision, so the success was, as a day case, 96%. Where the unilateral neck exploration, 92%. Bilateral neck exploration was less, much less, 84%. And the author concluded that with structured pathway, same-day discharge can be routinely and safely even in bilateral exploration. And the implication was day case parathyroidectomy in that study is safe as a standard practice with protocol for supplementation and follow-up. So what are the points which are with day case parathyroidectomy? First, lower systemic complication, as Flynn mentioned in his study. So the complication as an outpatient was 0.8 compared to 7 as an inpatient. And the readmission was statistically not very different. The comparable cure and success rate, the Flynn study and the ANISI, there is no difference in the surgical access or readmission between the two groups. Now, the high adoption rate in the national trend, طبعا Wang et al. In his study said that same-day discharge rose up to 74% in primary hyperparathyroidism. طبعا high same-day discharge success, 93, as Jank et al. In the UK study he mentioned. Long-term safety and stability by the study by ANISI. So he had like 2,900 over 20 years, and same day he said had a similar outcome. The feasibility with minimally invasive technique, Flynn and Jang et al. Showed that 94% of the day case patient has minimal invasive surgery. So what are the arguments against? طبعا not suitable for high-risk patient, as Flynn showed in his study, and ANISI, especially older patient or SA3 or patient with anticoagulants. And also the risk of post-operative hypocalcemia. Jang et al. In the UK study, he mentioned that they have 3 cases, as I mentioned. And also, it requires a strong infrastructure, meaning that they need like a lot of technology for rapid calcium parathyroid assay and follow-up system and adherence. And this was shown by these 2 studies. Now, it is limited in complex hyperparathyroidism, and like the secondary and tertiary, as mentioned by Wang et al. In his study. So he mentioned only 44 of these cases were discharged the same day, versus 79 for the only primary hyperparathyroidism. Bilateral exploration طبعا may warrant observation. Jang et al. He mentioned his study. The success rate was only 84 in the bilateral compared to 96 for the single gland cases. طبعا it is not yet universally supported or as standardized. So no global consensus about the day case. So what are the selection criteria for day case? So the ideal patient should be a primary hyperparathyroidism. It's a single gland disease, no low comorbidity, no bleeding, no airway risk, and also reliable social support. Yani when they go out as an outpatient, you have like access to the hospital and they're not far away. Day case is not suitable for, or less suitable for secondary and tertiary hyperparathyroidism, patient with multi-gland disease, or also patient who had done more than 1 surgery. Okay, or patient who are far away from the hospital. So the final takeaway, what I want to say, yes, day-case parathyroidism is a valid option. It is safe and feasible and effective. طبعاً it is supported by both single center and national level data, and it has an excellent outcome in well-selected patients. But be aware that inpatient is not for everyone, and that inpatient monitoring needed, that older patient, those with high surgical or anesthetic risk, patient with secondary or tertiary or requiring complex bilateral neck exploration. Thank you.
Thank you, Doctor. You saved us 3 minutes. Thank you so much. Now we would like to welcome Professor Saif Al-Subhi. He's section head and consultant breast endocrine surgery surgical oncology department at Center of Excellence King Faisal Specialist Hospital and Research Center. Professor Saif is one of the most distinguished endocrine surgeons in the Kingdom of Saudi Arabia and GCC region. He grew up in Saudi Arabia as a homegrown talent with over a 40-year professional experience. He will talk to us today about how to optimize the pre-parathyroid localization. Prof. Saif, the floor is yours.
Thank you for the introduction, Niles. And I feel happy that nuclear medicine also joined in this session. I would like first to thank Dr. Ali and the organizing committee to give us this chance to present about parathyroid. Now, Dr. Yasser gave you the nice face of the parathyroid. I will give you now the other face of parathyroid surgery. And I need the mic to be between the audience because I want some volunteer to share with me this session. So first, why we do parathyroid localization? We don't do it to confirm diagnosis. It's very important. Not to confirm or to rule out hyperpara. Because as we will see, some of the scan, even it is very high sensitivity, still we have false and positive, false and negative and false positive outcome of the investigation. We do it as our colleague, Dr. Yasser, showed that it is minimal. You can do minimal invasive. You can do it now as day surgery. You can have less complication, and you don't need to do bilateral exploration. So it is very important to have localization for this patient who have confirmed diagnosis of hyperparathyroidism. So what's the option we have for preoperative localization? We have many, and our colleague in radiology and in this nuclear medicine especially, it is increasing. The list is every year increasing. Now we have, after ultrasound, system EB, SPECT, we have 4D CT, we have MRI, we have PET scan, we have MRI with PET, we have even 4D MRI, and we have venous sampling, we have FNA, we have, and today our colleague also from nuclear medicine, she present about thyroid cancer, nuclear medicine. So we have many in the market, but of course not every hospital has all this facility. So what we use usually, we use what we have available. And I will talk about our center in King Faisal. We have, of course, ultrasound, you have SPECT, we have PET scan, PET CT, and we have the 4D CT scan. So we start usually with ultrasound just for thyroid, not to confirm, because we know it has a low sensitivity, but we depend on the SPECT. So most of the time we start ultrasound and SPECT, and if it is localized, we'll take the patient for surgery and stop there. Now we have a case which we did. She's a wife of one of our colleagues. She had classical hyperbara, primary hyperbara, and localized in the left superior parathyroid by PET scan, by SPECT. The patient have minimal invasive. we remove it, and she also intraoperative was dropped. But after 3 months, she started to have more of BTH increasing, and she has hypercalcemia, and she has now, we have to go back and find what happened. Pathology confirmed that we removed left superior parathyroid adenoma. Post-operative, she has a drop BTH, calcium normalized, but after 3 months. So I want somebody volunteer. What's the next step? What shall we do now? Anybody from the audience? From our young colleagues? Anybody volunteer from Kuwait, from Saudi Arabia? Okay, Dr. Yahya from Oman says we'll have to do okay, that's I agree. So what type of localization you will do? Yes, exactly. We go with simple, available, easy to interpretation. So we have the same. There is superior left parathyroid adenoma. So is it, it was imaginary, the pathologist missed it? No. So this patient had double adenoma. We removed the superior, and just above the superior, 1 centimeter up, it has undescended parathyroid adenoma. So it is at the level of the thyroid cartilage. We have removed it, and the patient 2 years now is normal calcemic, normal parathyroid. So scan can give you sometimes right answer, but not the whole answer, not the whole picture. We'll go to other case. This is Saudi gentleman, 59, was diagnosed also as hyperpara primary with mild hypercalcemia, triple normal BTH. What shall we do now? We go the same for localization. We did. So this is the spict in the chest. It is like the moon. Last night, it was very nice moon in the Kuwaiti sky. Yeah. So the patient went to thoracic surgery. They did VATS. They resected by minimum invasive without our help, just thoracoscopy, and they remove it. The patient next day has normal calcium, BTH dropped, intraoperative dropped, but unfortunately, 3 months later, the patient started to have hypercalcemia and high BTH. So what happened? Any volunteer? That's a good question about the pathology. The pathology was unfortunately parathyroid carcinoma.
Seeding of the field, they rupture it.
Okay, this one option, other option, but they are good surgeons, so. Any other option? Any other thought, differential diagnosis? Yes?
Metastasis.
Very good, yes, it can be metastasized. Other option? You will see the other option. So the patient, we did for him other localization. This is a pre-op. So this is the differential diagnosis. So the patient has right inferior parathyroid adenoma. So we don't know, maybe Dr. Reem can answer, why the PET scan pick up only the ectopic in the second case and miss the primary adenoma in the neck, while the first patient PET or SPECT pick up the regular or the same side, but didn't pick up the ectopic, the undescended. We don't know why the PET scan or the nuclear medicine behave like this. So this patient went again for neck exploration now, minimal invasive. We remove it, and it is parathyroid adenoma. So this patient has very rare synchronous parathyroid carcinoma, ectopic with adenoma. So parathyroid is very tricky. If you want to do parathyroid surgery, لازم يكون عندك صدرك واسع. You have to be calm and just wait for time. Don't rush. Don't do any horrific procedure if you don't or you fail in that procedure.
Since you need it interactive, did you check the calcium immediately after surgery in a few minutes and so on? Because if there was a gland there left behind, calcium will never, the parathormone will never come back to normal.
No, yeah,
agree with me or not?
We do intraoperative. We do intraoperative BTH.
Okay.
We do routinely intraoperative BTH. We use Miami criteria for all patients.
Okay.
So all of them dropped. So even the Miami criteria doesn't work sometimes. So we are planning to publish this case by our fellows, Dr. Thraya. So why parathyroid still have challenging cases? Because we know that parathyroid anatomically, umbilically immigrate from the neck, from the mouth to the neck, and during this immigration, it can stop somewhere, it can go somewhere. So ectopic parathyroid is very common, and we know that localization study is still, it's not 100%. It helps us a lot, and it make our life much easier, but still there is some drawback, some pitfall in these, especially nuclear medicine studies. We don't have until now 100%, and the confusion comes when you have more than one parathyroid. So that's what we teach our junior, that thyroid hyperparathyroid is primarily caused by adenoma, hyperplasia, or cancer. But this is not always right. Sometimes we have overlap between these three entities. Also, we don't know why sometimes we have parathymatosis, even if it is benign. And sometimes, even we do 4 gland resection, still you can have BTH high. That's most likely stimulation of the embryonic remnant of parathyroid tissue somewhere in the neck or in the thymus. So we go back to what we should do. As we said, each hospital has to have like a plan or algorithm for their plan for hyperpara. We start usually with ultrasound, SPECT, and from there, either we go for PET choline or we go for 4D CT. 4D CT, the problem is the radiation and also the reading. If you don't have somebody experienced in 4D CT scan or 4D MRI, it will be useless, actually. You have to have somebody who can help you in that. And usually, these cases are small parathyroid and usually ectopic parathyroid. So if you are lucky, you can have good radiologist, radionuclear medicine, good ultrasound operator, and of course, you need a good surgeon. Of course, even with all this experience, still we need some intraoperative. I think Dr. Ali will talk about autofluorance. Still, this can be helpful in some cases, and it can decrease the recurrence rate of resistant or residual hyperparathyroidism. This is just autofluorance. So I think parathyroid disease has varieties of biology. We don't know exactly why sometimes we have these pitfalls by X-rays, but you need to have a system or plan or vision about how you deal with these cases. I just mentioned this. And as we said, yeah, this is a reference. There are many studies in the net. You can have hundreds of papers about all these studies, but almost all are closed. Nobody superior, nothing superior. Nuclear medicine, CT, MRI still have like 95% with the good radiologists who can help you. But still, there is no evidence that one is superior to the other. And I think more is coming in the next few years. Thank you. I think I will finish here. I am on time.
Yeah, thank you very much, Prof.
Thank you.
You have 40 minutes, still more. Thank you very much, Prof.
Thank you.
Thank you. Now, I'm going to call Dr. Ali Sayed. Of course, everybody here in the hall knows who is Ali Sayed. But it's nice to say that he is the founder and the president of Kuwait Society for Endocrine Surgery. Dr. Ali, he will talk to us about the autofluorescence. It's relatively recent, or what I say, the relevant or recent one study. It is a kind of near infrared imaging study during surgery. So he's going to talk about near infrared autofluorescence, how it can help in the next surgery or endocrine surgery. Dr. Ali, for you can talk to for 1 hour. I'm not going to instruct you because the boss, you're the boss, and he may fire me. So, please.
Yeah, thank you, Dr. Mursi. Thank you, the both sharing person, and welcome again in Kuwait. And I'll try to make it so brief. And I made it at, let me say, at a level of my very humble opinion and experience in NIRAF. The problem, it's difficult to talk after Professor Subhi because he already changed my mind while I was listening to him. So I have no disclosure. What is near-infrared autofluorescence? It's a specific light wavelengths with selective illumination. For those who doesn't know what is NIRAF, I'm not against, but I'll tell you of what we have done in my hospital. And the objective of this talk, let's be serious. مننا فايدة ولا ما مننا فايدة? Is there a real benefit of utilizing NIRAF for intraoperative detection of parathyroid gland or not? I can give you the answer now. For the last 30 years, I'm one of the, let me say, I wouldn't say it, but I have to say sometime, I do around 40 to 45 parathyroid cases per year. Do you know what is the best way to localize it intraoperative? Two things. One of them mentioned by Professor Subhi. The other one, Professor Subhi said you have to be patient. This is number one. In parathyroid, you can finish in 5 minutes, and you can stay for hours. The other thing is your experience, your eyes. You have to localize it. You have to see it with your eyes. There is no excuse in doing parathyroidectomy without seeing it. These are the contents of my talk. Well, I wish it's easy like this. This patient took me, I swear to God, maybe 3 minutes. I just opened, it was there, looking at me. So this is not the reality all the time. This is another case where localization and to find the gland is really challenging. Now, up to 22% of those thyroid surgery, you may have injury to the parathyroid. And the permanent one can reach up to 5, and I found in some literature up to 10% permanent hypoparathyroidism. I can tell you, it's a disaster. It's easy to talk, it's easy to operate, to learn new things, but to visualize it sometimes with your naked eye, maybe it's not enough. The problem with the surgeons, they want to fulfill their ego and their moral that I've seen it, I'm sure, I just need someone to kick me to tell me, come on, close the patient, you finished, you have seen it. So probably the idea of NIRAF came here. And I think you know better than me why this gland can be injured, because it's small, the color is almost like a lymph node, like a tiny thyroid nodule, the blood supply, and the main thing that may add to the injury of the parathyroid, despite the fact you did not remove it, is the blood supply. The problem with the blood supply, and that's what I've seen with Professor Tayon when she did the robotic, and one of the advantages that I found with her, that the image is amazing. You can see the blood vessels going to the parathyroid, and the blood vessels of the parathyroid are not going from the inferior thyroid artery directly to the parathyroid. They are going to the thyroid, from the thyroid to the parathyroid. And that's the reason that even if you do capsular, even subcapsular dissection of thyroid gland, it may not keep your parathyroid without devascularization. So as has been mentioned by Prof. Subhi, there are so many techniques of intraoperative localization, pre-op. You all know about this. Methylene, people, they use methylene blue, gamma probe, gland PTH aspirate. I've done it twice only. Intraoperative PTH, which all of us, we do. Frozen section, internal jugular sampling. But all of them, they are invasive. Some of them require lab arrangement, time consuming, and still may not help you to find the gland or to preserve their blood supply. 2011, they forwarded the grant for the NIRAF by the FDA. They approved the device. And there are two devices in the market. The PTI, and I think it's available there, and the FlowBeam 800. And the idea, I will not go deep in how they are constructed, but they need a dynamic optical contrast imaging. You need a somehow called Raman spectroscopy, and the most important thing that you need a software, dark ambient, and sterile cover. This is the PTI. I think most of our senior colleagues, they know the PTI. Disposable fiber optic probe with a console housing NIRAF light source. And the good thing about it that you have an audio visual, so you can hear it also. The FlowBeam, that's what has been available now in Kuwait. Still, we don't have it, the PTI, but we have the FlowBeam. It's handheld camera where you give light, I receive light. And the idea, I remember I presented such a talk maybe 2-3 years back, that it's, I'll put it in this way. There are so many fluorescent things in our life. So it's not only the parathyroid or the gland or the human being. I'm expert in gemology, and I use the amber for beads and these things. So when you give them autofluorescence, you receive another light that makes me to say, yes, this is a true amber. So the idea is somehow similar. This one will result in generating signal and the process to the generator, and the generator will give you a very shiny picture on the, as you see in the picture there. And that's the shiny things called fluorophores, naturally occurring, or sometimes you have to inject the patient ICG to see them clearly. You see that shiny thing. The characteristics about the NIRAF, that it yields much stronger NIRAF. The lightening is too much, more than 2-3 folds of the surrounding tissue. And surprisingly, and I don't know why, don't ask me, it persists in ex vivo for 2 years, even with extreme temperature and formalin. And the responsible fluorophores, it's not 100% known, but they think that due to the cellularity of the gland itself, calcium receptor, and presence of pseudocolloid, NIRAF remains unaffected by the vascularity. So don't use it or think that it will help you not to devascularize. You can see the gland without any, and it can be a dead gland. So it doesn't read the blood supply. It has nothing to do with the blood supply. It's just a device or a technique to see that there is something shiny that could be parathyroid. When you add the ICG, this is the picture that you will see, a different way of, now here you can judge whether the vascularity of the gland is intact or not. Setup is easy. It's nothing, you need only a sterile bag, dim all the lights, which is really annoying. We keep shouting in the room, please dim the light, and they forget the ceiling light. My friends, they know here. And you keep it for like 15 to 20 centimeters away from you, and you use a marker, your forceps, for example, to see it. Now, another advantage that I found it myself, it can detect the adenomatous parathyroid by the heterogeneity of the gland. When the gland is too much shiny, it's more healthy. When it's heterogeneous and it's dim, it's most likely a diseased one. Sorry. Another advantage, it can, is it that slide? It should be this one. Can't see, maybe this one? Can you play this one? It's not playing. Yeah, the good thing about it also, or it may add to you that it can identify for you, especially the lower parathyroid glands, because they are so superficial. And sometimes we take it with the thyroid gland. So it can tell you that this is the parathyroid gland because they are more superficial. And we already talked about this. Another advantage also, in case of an advertent excision, you removed it. Have you removed it yourself, Dr. Ali said? Yes. If you don't remove it once, you didn't operate. So in case of accidentally removed it, you can reimplant it. So how would you know? You can use the NIRAF also. The other thing here, I want to show you that one of the advantages also is to see the size and relation of the intensity of the diseased one when it is, even if it is a small. So if it is a small, but it's shiny too much, then it's okay. The issue is when it is big and shiny, it's more healthier than the one which is really small and there is no infrared. So we already spoke about the ICG. Studies showed significant correlation between ICG uptake by the parathyroid gland with postoperative parathyroid. And it may be of value with patients with prior bariatric surgery because of the malnutrition. Disadvantage, you may require wider incision because you will do more dissection to find it. ICG used, then all 4 glands should be evaluated. Sometimes you need to repeat the doses, and when you repeat the dose of ICG, some residual fluorescence persists in the soft tissue, unfortunately. And the signal sometimes is not detected because it's deep, so all of this may add to your eager to extend the wound and go for more dissection. Does this require extra OR time? Well, I cannot answer this question, but it happened with me. There are a lot of talk in the literature. Fluorescence from the vicryl is another problem, from your suture, from your surgical ink, and you have to differentiate. So that's how I started, that you need to know where is the parathyroid anatomically with your naked eye, and then you put your near infrared device to say that I think this could be the parathyroid. You need an ambient OR light on and off. It's very noisy, very annoying. And it needs for a sterile bag, which unfortunately we don't always have it. So I need to ask someone to hold it for me from outside, or if I hold it, then I have to change my gloves. Evidence, the literature is variable. But they are not I mean, after revising so many articles, there is no statistical significant difference in post-op hypocalcemia between NIRAF and the control group. The other studies, single, multicentric, randomized trial, confirmed high parathyroid gland detection by NIRAF up to 100%. And we since we used it and we didn't do so much cases because the device was not always available, or we cannot reach, we don't have the bag, we have done, with the help of Dr. Ahmed Al-Bayati, soon he will publish it, inshallah, a small pilot study according to what was available for us. So we included the goiter with cancer patient, male, female, age 18 and above, and we excluded those redo, completion, parathyroid adenoma, end-stage renal disease, and the findings are almost the same as international findings. There is nothing, it's only that 20% risk reduction in the transient hypocalcemia, but still it's not significant. Maybe of value for spatial localization, that you can say that I think this is the parathyroid. And maybe of some value in reimplantation, could be, I'm not sure. So those are the pitfalls. You need to be careful that sometimes the near-infrared could be so shiny in colloid thyroid nodule, brown fat, and sometimes, if you are really unlucky, a metastatic nodule. Where you can use it, all these procedures, lobectomy, total thyroidectomy, completion, redo, we have done all of these, focused parathyroidectomy, all types of neck exploration, dissection, bilateral parathyroidectomy procedure with autotransplantation, reoperative parathyroidectomy, and joint procedure, thyroid and parathyroid. In conclusion, Mr. Chairman, I want to say that both devices are safe, despite I did not use, because it's not available, the PTI in Kuwait, but both are safe, effective, considered as an adjunct tool, and they are not used for diagnosis, please. Image-based is more valuable for spatial localization, while the probe-based is more sensitive quantitatively, by the way, because you can see and hear and see the number, and accurate in parathyroid identification. So, to end here, more studies are needed to assess the cost effectiveness, assess if it is truly minimize the post-operative hypocalcemia, determine whether it can reliably find you the abnormal parathyroid glands, investigate if it really decreases the rate of recurrence hyperparathyroidism. Should someone consider seeing it by NIRAF as an optical frozen section? It's a long discussion. I don't think so. In low volume center, it may add to learning curve. Adding ICG can avoid devascularization. Direct surgical field image is more convenient, which I mean if in the future this way of looking at the monitor and going down looking to the surgical field can be changed by only looking at the field would be great. Technology that defines the blood supply without using ICG, this is the future if we can do it. And thank you very much. Thank you for your listening.
I said 1 hour, but actually it took only 40 seconds. Thank you very much, Dr. Ali.
We'd like to welcome Prof. Saif again to the floor. He will talk to us now about the intraoperative maneuvers to avoid parathyroid devascularization and role of reimplantation.
And I thank Dr. Ali to choose this subject. I don't know what to do, but I will give you anatomy and physiology. Then it's up to you if you can save the parathyroid. It's a very important subject because we know in the world there are thousands and thousands of thyroid done almost every day or every week. Endocrine surgeon as a discipline, I think in the last 3 decades have successfully improved the quality of care for patients suffering from endocrine disease, especially in the decreasing the rate of recurrent laryngeal nerve, decreasing the rate of hypopara, using minimal invasive, robotics, intraoperative, many aspects. But I think still we have a problem with the hypoparathyroidism, permanent and transient. So in this presentation, I will try to give some recommendations, some tips how we can improve our result of preventing especially hypopara, permanent hypopara. As Dr. Ali have alluded a lot of anatomy and of parathyroid, hypoparathyroidism, if you see a young lady in her 30s and taking calcium and vitamin D for the next 20, 30 years, you will appreciate how important it is to save the parathyroid. It is very vital. I have seen some patients who have tetany, who have going to the emergency room for IV calcium. So hypoparathyroidism is very bad complication of thyroid surgery. And the most common, of course, is the surgical. It is the surgeon who causes this mainly, because their attention to cure the patient from thyroid cancer or huge benign disease. Especially in our area here, I think Dr. Yasser, when he talked about one-day surgery or same-day procedure for parathyroid, it is most of the study coming from the West. But here in our area, we have also to remember that our people have here high incidence of vitamin D deficiency. So some of these patients, even after hemithyroidectomy, even after small parathyroid, they can have hypocalcemia. So please consider also that some of these patients, after total, they can go on bone hunger syndrome. So we have to discuss three angles of the subject: the location, blood supply, and the auto or reimplantation. Of course, anybody, as I said, want to do parathyroid surgery has to know very well the embryology, the physiology, the anatomy of the parathyroid, thyroid, and the blood supply. So here, no, where is the point? It's not moving. So there are three aspects of the presentation I will focus on. The location, how to look for the... No, how to move the slide. It's not moving. How to find it, the location. Then the second, very important, is the vascularity, how we keep the parathyroid vascular. Because most of the time, especially experienced surgeons, they will find it. They will find the parathyroid, and if it is in the regular place. But if not, this is the problem. If you find it and you find the vascularity, keep it, you will succeed. If you don't find it at all, this is other problems. Not lucky, yes. So superior parathyroid usually is easier than the inferior, because the superior is most of the time in its location. The inferior, it is problematic a little bit because it migrates with the thymus. So always the inferior one, which sometimes have a problem with it. So how we look for it? We look to the regular place. We know, just get your eyes to see parathyroid all the time, so you can have experience about it. Also, the ectopic, you have to consider always there is ectopic place for parathyroid, even if it is normal. Now, if you find it, this is the inferior. As we said, it is always, or there are like 15%, 20% of the inferior parathyroid is ectopic. Now, how we look for it? If you don't find it, there are landmarks. You know it very well, I am sure, as endocrine surgeon. You look for the recurrent laryngeal nerve. You look for the Zucker-Kandel tubercle. You look for the thymus gland, and you look for the thyroid poles, of course. We know that superior parathyroid usually is posterior to the recurrent, the inferior. This is the classical studies finding. Zucker-Kandel is very good, also landmark. Look for it. This is the recurrent. This is classical, but not all the time. Sometimes the superior is anterior, sometimes the inferior is posterior. So, but we are talking about like 75% of the patient, this is the situation. Zucker-Kandel. Zucker-Kandel is very important landmark. And it is like arrow, differentiating between the superior and the inferior parathyroid. Of course, this is the migration of the inferior. It can be anywhere. This is minimal invasive. If you don't find the parathyroid in its local or usual, what you will do? Shall we go and look for it? Do more dissection, or keep it, just keep it alone? Anybody volunteer? Who will look for it if he doesn't find it? Who will not look for it? Please raise hand. Very good. Because there are few literature have compared patient who, or who surgeon who start or look for the parathyroid. More dissection, it means more complication. As Dr. Yasser mentioned in central neck dissection, there is always a price you have to pay. You drop the thyroglobulin, but you increase the hypopara. It's the same here. If you dissect, look for parathyroid. If it is not in the usual place, just leave it alone. It is ectopic. Maybe it is the only one will work. So, and this is approved by some literature that more dissection will cause more hypopara. Okay, one of the advantage actually of autofluorance, as Dr. Ali mentioned, is they have studied extensively, some of the centers study the anatomy of feeding vessels for parathyroid, because as we have taught in the medical school, the parathyroid gland has supply from the inferior thyroid artery. It is endpoint, coming like branches, stop there. It is not the situation, unfortunately. It is more complex. And this is from Dr. Faris bin Muwallid from Marsilia. He have very good paper. If you want to look at it, it is very nice, very interesting study. And he studied the relation between the artery, supply the parathyroid, and the thyroid. So theoretically, or in fact, some parathyroid, you will never be able to preserve it, whatever you do. Either you have magnificent, you have laparoscopy, endoscopy, or you have the experience, some parathyroid blood vessels coming through the thyroid. So if you want to remove the thyroid, you have to sacrifice the parathyroid blood supply. So this is the importance of looking after you finish, you find the parathyroid, look to the color of the parathyroid. If you have the ICG facility, do it for that particular. And I don't agree, or I don't think it is feasible to do ICG for all cases, for all parathyroid. So if you are in doubt, maybe you can fix it, or you can, the other option is to auto-transplant. So this is very good study, and give you the right concept of blood vessels, that you have to be very meticulous with the parathyroid gland. The other problems in the superior parathyroid gland, as we can see here, there are like 6-7% of superior parathyroid gland, the blood supply coming from the superior thyroid artery. So, and most of the time there is anastomosis or overlapping between the inferior and the superior for the superior thyroid. If it is only the superior, there is very high risk that the superior will lose its blood supply because you are tying the superior. Even if you give the posterior, try to preserve it, still it can damage or devascularize the superior. Here the picture, the dense of vascularity in the whole thyroid area. As we said, this is the classical teaching. Inferior thyroid artery, go branching, go up and down to supply the parathyroid, but unfortunately, it's not the case all the time. You can see the superior parathyroid sometimes have long branch of the superior thyroid artery, which is very easy to damage. So sometimes it is impossible to preserve the blood supply of the superior if it is the only blood supply from the superior thyroid artery. So this is the classical picture. I think you have seen it many times. This is the subcapsular. Try to go up, above the parathyroid gland as much as you can, and dissect the parathyroid, keeping the blood supply, which is coming from the lateral and posterior branches from the inferior and superior thyroid artery. They have good papers about the inferior parathyroid blood supply coming from the thymus. There are like 15% of the inferior parathyroid blood supply coming from the thymus. So it is very important also to do meticulous preservation of the thymus. Don't try to dissect it or resect it, or if you want to do central neck dissection, they advise to do it between the thymus and the trachea in this plane. So you avoid damaging the blood supply from the inferior branch from the thymus to the inferior parathyroid gland. Of course, even, and you can imagine, even if you damage the venous system for the parathyroid, you can have congested parathyroid and ischemic parathyroid. So it is very sensitive organ, doesn't like manipulation. It needs to be left alone and try to preserve it as much as you can. All these are paper, very good paper, written about the inferior parathyroid artery coming from the thymus. As Dr. Ali have mentioned, there are intraoperative tips, like try to do bloodless field so it will not be stained, the parathyroid, because the color is you can easily differentiate it from other if there is no blood. And also you have to have enough exposure, even if it is minimal invasive. Try to have good exposure to the nerve, to the parathyroid, and looks, as we said, looks to the normal size. I try not to use irrigation, try not to use suction. I try to use just wet swab for retraction, because suction sometimes can false the parathyroid. As we said, the thymus is very important. How many minutes I have, Doctor? Only? We'll take from Dr. Ali time. Now, there are many things coming in the market. Autofluorance, camera, IBT. IBT also is annoying because you have to have a goggle. You have, the probe is easy to lose. Carbon nanoparticles, Raman, spectroscope, laser. There are many things in the market. So I will just skip this for reimplantation. This is very good study also, which is done by Italian group, and they have studied like 32 studies, review 32 study with 4,000 patients, and of course the recommendation is to, if you have devascularized parathyroid, is to implant it. I implant it in muscle. Some people implant it subcutaneous. Some people in the forearm. I think I have to reach. Dr. Reem looks annoyed. So it is important to re-implant. And very important not to have hematoma in the bucket, so you can have survival, parathyroid tissue. It is very important. It takes you 2 minutes, but you can save the patient 30 or 20 years of calcium and vitamin D supply. And I think I will have to finish there. This is the conclusion. Thank you again for creating.
Thank you, Prof, so much.
Me or you? Okay. So I'll call the last speaker. He will talk about parathyroidectomy and end-stage renal disease, nephrologist view and recommendation by Dr. Mohammed Al-Mu'min. Dr. Mohammed Al-Mu'min has a big CV, but he's a consultant nephrologist working in nephrology unit at Mubarak Hospital. Mubarak Abdullah Sabah Dialysis Center. He obtained his medical degree from the Royal College of Surgeons in Ireland and completed his medical residency program in Kuwait. He obtained his nephrology fellowship training from Manchester University in Canada. He was followed by specialty training in whatever. I do not really read English well. So Dr. Mohammed Al-Mu'min, I'll give you also 15 minutes, okay?
Sure. Thank you, Mr. Chairman. Good evening, everybody, and assalamu alaikum. It's a privilege to present in this unique symposium. As my topic said, parathyroidectomy and end-stage renal disease. It's a nephrologist recommendation, so it's obvious, that I'm internist, and we are internists, we like to talk a lot. So buckle up and bear with me. So today I'll focus on when and how we should think about parathyroidectomy in the context of end-stage renal disease and kidney transplantation.
You ask us, please just come to the mic, please, because thank you.
Okay. So today I'll focus on when and how we should think about parathyroidectomy in the context of end-stage renal disease and kidney transplant. We'll look at the mechanism, evidence, and then translate that into a practical, clinical level recommendation. The emphasis is who should we refer, when, and why it matters for patients' outcomes. Yeah, it's not. It's changing this one. Sean? No. خليه هو يقلب هناك or I can go over it. Yeah, okay. You can flip the slides from there. I can just ask you to flip it, okay? So next slide. Okay, so this is the roadmap. I'll start with primary hyperparathyroidism, mainly to contrast it with what we called it CKD MBD, chronic kidney disease, mineral bone disorders. Then we move into this, again, the CKD MBD and transplant-related hyperparathyroidism, evidence comparing medical therapy and surgery. And finally, I'll give you a simple stepwise referral algorithms that we can apply in practice. Next slide. Okay, just move the slides. So I'll briefly remind you of primary hyperparathyroidism, so we don't mislabel CKD and BD as primary hyperpara. So primary hyperpara is characterized by inappropriate PTH in the setting of normal or high calcium and interplead vitamin D. Most cases are due to single adenomas. Move, next. There is also the normocalcemic variant that can still cause skeletal and normal complications like stones and fractures. Next. And we must always keep in mind the familial hypocalciuric hypercalcemia, particularly in a young patient with mild hypercalcemia and low urine calcium, because surgery won't help those patients. Next slide. So clinically, many primary hyperpara patients are discovered incidentally with mild hypercalcemia, but the disease burden can be significant. Renal stones are common, and large proportion have osteoporosis or vertebral fractures. Classic osteitis fibrosa cystica is rare today, but still useful to recognize radiographically. Keep in mind that cardiovascular phenotype as well, like left ventricular hypertrophy, hypertension, and vascular disease, are all more frequent even in the so-called asymptomatic patients. Patients may also present with non-specific symptoms, systemic symptoms such as weakness, fatigue, cognitive, or neuromuscular symptoms. Next. So switching now to CKD-MBD, or chronic kidney disease, mineral and bone disorder, which is really the background stage where our secondary hyperpara develops. This is not just a bone disease, it's a systemic disorder involving bone, vasculatures, and mineral metabolism. In dialysis patients, CKD-MBD and vascular calcifications are major drivers of fractures, cardiovascular events, and mortality. Next. Can use this? Okay, good. So this slide ties the biochemical abnormalities to clinical outcome. As GFR falls, phosphate retention and rising fibroblast growth factor 23, or FGF23, suppresses calcitrol, driving PTH up. The same milieu promotes vascular smooth muscle cell transformation and medial calcification, which leads to arterial stiffness and LVH. So when we are treating PTH, we are really also trying to protect the heart, the vessels, not just the bone. So histologically, we see a spectrum of bone disease. Many of our dialysis patients sit at the high turnover end, which is the right side of the screen, with severe hyperparathyroidism, but a significant proportion, especially with calcium-based binders and high dialysate calcium, develops adynamic bone disease, which is the right side of the graph here. The important point, both extremes are harmful. It is not only high PTH is bad, but also very low PTH with adynamic bone disease also carries higher mortality. So KDIGO gives us ranges rather than a single magic PTH number. So in end-stage renal disease and dialysis patients, the aim is a PTH of about 2 to 9 times the upper limit of normal. Persistent values beyond that, especially with high calcium or phosphate, with the medical therapy like phosphate binders, vitamin D analogs, and calcimimetics, should trigger us to think, is this now a surgical disease or not? As parathyroidectomy is explicitly recommended in severe secondary hyperpara not responding to optimal medical therapy. So even if we fix the kidneys with a transplant, the parathyroid glands do not always get the message. Persistent or tertiary hyperparathyroidism is incredibly common in the first year after transplant, up to 80% of cases, and does not fully resolve in a large proportion of patients, which may exceed 50% of them. This persistent hyperparathyroidism is not benign. There is a clear association with fractures and, unfortunately, graft dysfunction and mortality. So persistent hyperparathyroidism after kidney transplant vary, but most studies consider PTH of above 10, or even some of them consider PTH above 7.5 at 1 year post-transplant as persistent hyperparathyroidism, What matters clinically is the combination of PTH, calcium phosphate, and symptoms. High pre-transplant PTH or use of calcium mimetics, long dialysis vintage, and large glands are on imaging are red flags that the patient may carry secondary hyperpara into the transplant era unless we intervene. So this slide summarizes why we should care for those patients. As persistent hyperpara is not just a lab abnormality, it drives fracture, cardiovascular disease, calciphylaxis, and graft loss. In the transplant setting, hypercalcemia and nephrocalcinosis can directly damage the allograft. It is also associated with a decreased quality of life and increased mortality. So the question becomes, how long do we keep the patients, or how long do we keep adjusting medications before we send the patients to surgery? So medical therapy remains first line here. Vitamin D analogs improve the PTH, but there is a risk of hypercalcemia and hyperphosphatemia, so we use phosphate binders with it, which are essential for phosphate control. Calcium mimetics are powerful tools, especially in the dialysis patients, but they have limitations, like once glands become large and nodular, they are less responsive. And in the transplant setting, calcium mimetics can mask the true severity of hyperparathyroidism pre-transplant, only for it to rebound later on after transplant. At some point, or in another word, we are simply postponing surgery rather than avoiding it. So key studies are important. We have the Cruzado and colleagues in 2016 showed that surgery clearly outperformed cinacalcet in terms of normalizing calcium level, lowering the PTH, and improving BMD. And they showed that the PTH levels can decline as fast as 10 minutes after surgery. And over longer follow-up, Moreno groups proved that surgery also lower the recurrence of tertiary hyperpara. So calcium mimetics are useful, but not equivalent to hyperparathyroidism when disease is severe and structural. So trends in parathyroidectomy, since cinacalcet was introduced, I would say 20 years back, the surgeons operated less as parathyroidectomy rates declined by around 40% after the cinacalcets became widely available. And there was a decrease from a US data from 7.9 to 5.4 cases per 1,000 patients over a decade, with a sharp drop after the year of 2004. That sounds good initially. However, despite this, severe refractory cases of secondary or tertiary hyperpara with adverse outcomes remain common, which also means that some patients who would actually benefit from definitive surgery may be left on the high-intensity medical therapy for years prior to doing the surgery. The challenge is to identify which patients should not just be managed medically and should be sent for surgical management. So timing for parathyroidectomy is crucial. Data suggests that a pre-transplant parathyroidectomy is the safest window for the kidneys and the patient. If surgery is done early after transplant, there is a noticeable short-term hit to the kidneys and GFR. It tends to stabilize, but some patients would rather, some physicians tend rather avoid that hit in the newly transplanted kidney as much as we can. And a lot of sparse evidence behind the timing of the surgery. So indications for pre-kidney transplant parathyroidectomy, I would say this slide I would keep at your desk. If you see a combination of very high PTH, large glands on imaging, refractory biochemical abnormalities, or calciphylaxis, this patient is a strong candidate for pre-kidney transplant parathyroidectomy. These are the ones who are likely to have persistent hyperpara that will harm the graft after the transplant if surgery hasn't been done. So I will skip this slide, as already mentioned by Dr. Ali and our colleague. So post-parathyroidectomy outcomes and complication. Overall, parathyroidectomy is a highly effective as we can achieve durable control of PTH and calcium, improved BMD, bone mineral density, and reduced bone turnover. However, it is not trivial. Hypocalcemia, especially hungry bone syndrome, is common and needs careful post-operative management with high-dose calcium and calcitrol. From our side, we closely coordinate with our surgical colleague, endocrine services, especially around dialysis, prescription, and calcium exposure is essential in the first days, 2 weeks post-op. Other complications, as we know, with the transient or permanent hypoparathyroidism, some surgical complications like infections, recurrent laryngeal nerve injury and palsy, myocardial infarction and arrhythmias. Mortality during hospital stay or within the first month is around 2% post-op. So KDIGO is supportive of parathyroidectomy in the right patient with severe secondary hyperpara refractory to medical therapy. And the KDIGO transplant candidate guidelines specifically warns against transplanting uncontrolled severe hyperparathyroidism patients. That gives us a guideline-based mandate to intervene before we put in a graft when the parathyroid disease is clearly or severely not controlled or refractory. They both advocating that post-kidney transplant, we should treat CKD MBD abnormalities as for CKD grade 3 to 5 with attention to persistent hyperparathyroidism. So from what has been mentioned, this is a practical summary. I would say step one, we start with best optimized medical care, correct calcium, correct vitamin D deficiency, optimize phosphate control and dialysate calcium, and the use of calcium mimetic appropriately. Step two, risk stratify the patient with regular follow-up of metabolic panel imaging and bone studies. However, if the patient remains biochemically uncontrolled with large glands or complications, escalate to surgery, ideally before transplantation. In the post-transplant setting, we usually give up to 1 year for spontaneous improvement. After that, persistent hypercalcemia or hypercalcemic hyperparathyroidism with evidence of bone or graft impact is a strong indication for surgery. So to close, not every high PTH needs surgery, but some clearly do, and those patients benefit from timely parathyroidectomy, ideally before transplantation. As nephrologists, we are the ones who see the long PTH trajectory and can advocate for those patients early before they accumulate irreversible vascular and skeletal damage. So my key take-home messages here, secondary or tertiary hyperparathyroidism are central in CKD MBD and strongly impact bone, cardiovascular system, and graft. Medical therapy is the first line, but has clear limits in severe nodular long-standing disease. Parathyroidectomy provides superior long-standing or long-term control of PTH calcium and better BMD with lower recurrence of tertiary hyperpara. Pre-kidney transplant parathyroidectomy is generally the optimal timing in high-risk candidates, and nephrologists should lead early identification and referral within a multidisciplinary team approach. With that, I will end my talk. Thank you very much for listening.
Thank you, Doctor, so much. I would like to ask the speakers to come to the podium for the Q&A. يعطيك العافية دكتور. Nice talk. I would like first to thank all the speakers. It was a really great session, very great talks. Thank you all. I will take the privilege to be the moderator and ask the first question. For Prof. Saif, about your case that you presented, the parathyroid carcinoma, and then they found, I think, left parathyroid adenoma after they resected the carcinoma. My question is, you mentioned the image. Did they do a SPECT CT or a SPECT in the first carcinoma the first time. So they did the maybe SPECT only, not SPECT CT. That will answer your question for why they didn't see the parathyroid adenoma. Hence, maybe due to the small size, maybe, and the SPECT CT definitely will be more specific, more sensitive in these cases, especially in the small sizes. And also, we can take into consideration that the carcinoma was a huge mass and with a great uptake. Maybe then after it's been resected, the small adenoma showed more obvious. So most of our centers now are doing SPECT CT, which should give us more resolution. And of course, you all know the limitation of SPECT CT on the small sizes, definitely.
Yeah, absolutely. You know, nobody expected that this is cancer.
Yeah.
Because the BTH was not very high, calcium was not very high. So we take it as it is a regular adenoma, typical adenoma in the upper chest, in the mediastinum. So, but it was surprising for us. The pathology showed there is invasion of the capsule, invasion of the lymphatics. But that's what we start, usually with simple system EB scan.
Okay.
With the SPECT. But we didn't go to other more advanced, unless it is equivocal or not. But my impression, you know better than me in nuclear medicine, but I think the contrast or it will go to this big volume of parathyroid tissue, especially it is cancer and maybe it's metabolized more. And, and the adenoma, after we remove the cancer, it is the only one now. So استفردت فيها الأشعة. So it was clear after we.
Prof. Subhi, out of curiosity, now, since you know after surgery that the one in the mediastinum is parathyroid carcinoma, it's not adenoma, did you went in again to clear the margins, take more tissues around?
No margin,
Because the trend in parathyroid carcinoma, you have to remove it en bloc. So I don't know how you manage the case. This is my first question. The second question, in parathyroid carcinoma, as you all know, the PTH is quite high. So I don't know how your case is low PTH.
Because of this, I mentioned in one slide, parathyroid gland is not like what we think, adenoma, carcinoma, hyperplasia. I think there is mix between, biologically, there is a mix between all these elements, because not all cancer have very high PTH, very high calcium. And I cannot explain why this patient with renal failure, when you rupture the capsule, they can have parathematosis. And you can see it under pathology and microscope. There is pathology, segment of, but no invasion. So, and it is benign. So I cannot explain why it's not typical or classical parathyroid carcinoma. And for the block resection, some literature support you do hemithyroidectomy with the parathyroid cancer if you discover that parathyroid is this cancer. But most of the time it is incidental finding after surgery. So people are controversy. You go back to remove the thyroid or you don't remove it. Many studies didn't show any benefit.
Sorry, I have a question for Dr. Yasser. Dr. Saif already alluded into that topic. Our patient here in the Middle East, they are different type of patient. In a way, most of them will have vitamin D deficiency, and most of the patient with parathyroid adenoma will develop hungry post syndrome post-operatively. So day surgery, though it's doable, we can do it, but it should be selected for certain type of patient who understand their disease, who are motivated, who have a safety net. So in your practice in Bahrain, do you do same-day surgery? That's number one. Number two, if not, do you think we're going to be doing anything differently, like we give the patient some calcium pre-op or vitamin D activated and then send them home right after surgery?
I totally agree with you. Most of my patients, I keep them for more than 24 hours. So it's mainly like Western studies. I don't feel safe really to keep as a day case, unfortunately. And I always check the vitamin D Now, not only for the parathyroid, also the thyroid operation, I try to correct the vitamin D before doing surgery. Okay?
I learned actually the hard way. My first parathyroid, when I came back to Kuwait, patient came in 72 hours to the hospital with tetany.
Yeah.
So, and then I learned, I said, nobody home until I checked and do everything. You know, it was like my first parathyroid. I still remember it vividly. This was like 6 years ago.
Just one patient, tetany, you will learn. Very bad. I remember in the old days, doctor, I have a lady, I did for her thyroid cancer. She was a nurse. And that lady, she had a bariatric surgery, bypass. And she has a lot of lymph nodes with metastasis involved. So I have to do like a good central dissection and this one. Unfortunately, she has hypoparathyroidism. Now, though, she stayed like almost 1 month in the ward. We know يعني, the normal calcium gluconate, يعني, you have like a special calcium for these patients, calcium citrate you have to give them because the other types, they are not well absorbed, the oral medication. So I remember I looked in the research about these cases, and I think the best thing is to do like stage procedure. You remove one side and then wait and do the other side. So one patient.
Make you learn the hard way.
Professor Subhi, you know, I'm very glad to hear from you that whenever you are stuck, you know, you don't find the parathyroid, stop. But for the senior surgeons like you, and I'm sorry, or the surgeon's ego, I don't know about you, would you accept this? Because, you know, I'm very glad you stated that, but for the moderate surgeon, so on, he will keep looking and so on. Just give me a comment on that. Yeah, it was clear in your presentation, but I want just to focus on it again and again.
You are absolutely. I advise everybody, if you don't find parathyroid in its local position, stop there. Don't try to do more dissection because, as we mentioned, parathyroid blood supply is very meticulous, very, very small end vessels, and it can easily be damaged. So if it is an ectopic, maybe Allah كاتب لك انها تعيش يعني. Leave it alone. This is the message. And I want to comment on the parathyroid same day procedure. I think always our study coming from the west or from the east. I think in the area here we have to have our own studies, our own. There is one study in Medina, I think, in في المملكة. They try to do like hemithyroidectomy and total thyroidectomy as day surgery. And there was a lot of concern about it because of the vitamin D deficiency. And so we have to do our own practice, our own study, as we consider our population. Yani, Dr. Nephrology, Dr. Muhammad, showed that we have most of our renal patients on dialysis, they have all the complications, unfortunately. It's not like in the West, and the waiting list for kidney transplant in the CC is very long, and these patients are very sick patients. So it's different than what in the West. So these patients need more care, they need vitamin D, they need more dialysis. So we have to consider our population.
Agree. There are too many questions on the online for Prof. Saif. One of the question is, would you still do a localized based on the imaging modalities for the recurrence or exploration, or both together in case of parathyroid adenoma?
Which study? Again?
That's the question.
No,
localized based.
How many studies would you? We will start with a simple one, like system EB or SPECT. If it is clear, we'll stop there. We'll not do anything else. If it's not, we go to the 4D CT. No, we go to the bit scan.
Choline, yes.
Choline, bit choline, 18 choline, because we have experience in that two modality. My personal experience, I don't have any experience with the MRI bit scan
4D.
or MRI 4D. Yeah. And we have, fortunately, we have radiologists who have fellowship in bit choline and fellowship in CT 4D. So we are lucky
to
That
have
is-
both.
Yeah,
Excellent.
and we go and they show us. It is very important. The communication with the radiologist, with the endocrinologist, always very important.
Very
for-
important.
I
for
think,
practice of
Professor
endocrine
Subhi, the
surgery.
question was whether would you go for minimal invasive in cases of recurrence based on the images. If the images find localized disease, would you rather go for minimal invasive or bilateral exploration?
No, we'll go for minimal invasive, still.
Okay, another question is during total thyroidectomy, do you think ICG perfusion mapping should become a routine or objectively confirm parathyroid viability instead of relying on color alone?
This question is a very good question. I don't have answer. There are some study now doing ICG routinely. I don't think it is cost effective. Myself, I use flow beam, but I don't use the ICG. I depend on my eye. I try to do irritation to the capsule. If there is irritation, that means if it is a black and dusky, this is for sure, you need to take it and reimplant it.
Okay.
So I depend on my eyes.
I have a question, Dr. Ali and Dr. Muhammad Momin as well. Dr. Ali, do you think we can extend this NIRAF to surgeries other than the parathyroid and thyroid? Means, for instance, neck dissection for cancer anywhere, esophagus, larynx, and so on. Can we extend this? Can it help in this?
I think also a breast for the sentinel.
NIRAF is used in many procedures. By the way, it is useful also in adrenal gland, adrenal surgery. And when we say NIRAF, you're looking for something which, because I've been in this for a long time, not because of the NIRAF, because of my other specialty, Dr. Tay, she knows this, and the amber and the gemology. NIRAF is something like you're looking to the window or to the, if you remember the old films and the negative one, now there's no negative. Maybe the young generation, they doesn't know. This is NIRAF, it's just to look at the things from a different view. So wherever is the fluorophores, that gives you like emit lights, yes, give it any light and it will return back to with a different light. It's like a power, you give it and you should receive something. So can be used in, definitely you can use it in breast, they are using it in adrenal gland also. But when we say endocrine neck surgery NIRAF, we definitely mean parathyroid.
Dr. Mu'min, you gave one year cutoff. Can we extend it for more longer time? Because, we as surgeons, we are, spectacle to operate on successful renal transplant with some improvement. So can you extend this to 2 years and so on, and wait, or just this established protocols or established guidelines?
Sorry, you mean to operate post-kidney transplant for the parathyroid?
Transplant, yes.
Yeah, well, the data showed that some patients or majority of patients might improve within the first year after transplant, but there is still some percentage that do not respond. So the KDIGO transplant guidelines recommended if patient was controlled within pre-surgery, so it's better to give him that period until the kidney stabilizes itself, because we know the rejection rate is very high within the first year after transplant. Yeah. So once the patient is controlled within the first year, that's well and good. If not, then you can operate.
This is why I'm asking for to extend period more than 1 year, because the patients are immune suppressant and so on, and they're critical. So yeah, this I'm asking.
Well, I would say they recommended or mentioned 1 year because now the rejection rate is less, or is almost, I would say, I don't remember the number, but definitely less than 10% or 5% after the first year. So it might be safe to operate.
If I can comment on this, I have operated patient 3 months after transplant because of hypercalcemia, and the graft start to deteriorate. So I think it is very important to follow up the function of the kidney, graft kidney. If it will start to deteriorate with hypercalcemia due to the hyperbara, you may operate in 1 month or 2 months to save the graft.
Okay, I think we have only one question more.
Yeah, mashallah, التفاعل very nice. Too many questions, but only room for one more question for Prof. Saif. Do you prefer total parathyroidectomy or subtotal parathyroidectomy in secondary hyperparathyroidism, and why?
بروف سيف ماخذ الجو كله
إيه.
فاحنا ما نقدر.
لا في other questions but no more time.
It's a topic for me. For renal disease, end-stage renal disease, I do total and reimplant in the arm, forearm, in the radiobrachial muscle, because it is easy to diagnose, easy to remove. For hyperplasia to genetics, primary hyperplasia, I do 3.5. In the neck, I keep the half in the neck because it is easy to find. I mark it with a stable, with metal stable, and it is easy to. But for renal transplant, for renal failure, because they have high rate of recurrent hyperbara, I put it in the forearm. I don't mince it. I put it small piece in different bucket, because some of these patients, it can grow like cancer in the muscle.
By this, we can conclude our session. Thanks for the speakers and thank for the audience. I think we have a short break. Ali? Inshallah, have a break. How much? How long? Take a break? 10 minutes? 10 minutes. Thank you very much.
So I would like to thank the moderator of this session, Dr. Mohammed Mursi. Thank you very much for your attendance and your sharing. صفقوله يستاهل، الشايب يستاهل. دكتورة ريمة محمد أبو شوارب، وشنب على شنب، تستاهلين كل خير. Thank you very much for your attendance and for your sharing. Thank you. So please, can we start the last session? I promise that we'll make it fast. Yes. This is the last session for today, and it will be moderated by Professor Kai-Wok Chung and Dr. Sundus Lid'aj. Dr. Sundus, she is a consultant endocrinologist, and she is one of the pioneers in adrenal glands. So the floor are yours, 15 minutes. So we'll see you in the session. Please go ahead.
Good afternoon. We'll start now the third session. Our presenter is Dr. Ahmed Ismail. Dr. Ahmed Ismail, he's a senior specialist in endocrinologist in Jabir Hospital, and he got his degree from France. He had an BBS with honor grade, and he got his fellowship in endocrinology from France. We welcome Dr. Ahmed Ismail. He's going to present for us adrenal incendiatinoma and the indication for surgery.
Okay. Assalamu alaikum. Thank you, Dr. Sundus, for the kind introduction, and thank you, the organizers, for inviting me for this talk. I would like to start by just saying that this is a huge and heavy topic, so I will have 15 minutes to run very fast. So, I have no disclosures related to this topic. Now, the learning objectives will be basically focused on knowing how to deal with an adrenal incidentaloma. So basically looking at the risk of malignancy, looking at the functionality, and what matters most to you all as surgeons is, do you operate or not? So adrenal incidentaloma, it's defined traditionally as any mass in the adrenal gland more than 1 centimeter that's found by accident during a routine examination for another reason other than looking at the adrenal. And we know it's very common. The prevalence varies according to the population that's been studied or the series. So it can be from about 1.5 to 7%. And obviously, as any other gland, endocrine gland, the higher prevalence is seen in the elderly population. We see them in about 1 to 5% of CT scans, and 75% are benign and non-functional. So as with anything in medicine, we start with the initial assessment. We look at the history and physical examination. The first thing, I think, and the most important is to ask yourself, does the patient have any previous malignancy? Because that will change the paradigm and how you look at this mass. You want to look at symptoms and signs of any hormonal excess, such as Cushingoid features, resistant hypertension, or very difficult to treat diabetes. I have a colleague that diagnosed a disease just based on diabetes that was well controlled previously and then suddenly was erratic. Sudden virilization, especially if you see an elderly lady in her 60s who talks to you about increased hirsutism that was not there before, she never had PCOS, that also, brings an alarming sign. Dizzy spells and palpitations, you might be thinking about pheochromocytoma, and unexplained hypokalemia, as we see with hyperaldo. Now, the question that you want to ask yourself with any nodule, with any mass, is it a benign or a malignant one? Now, that's based on radiological assessment primarily, and most of the time it's a non-contrast CT, and it can be sufficient if the spontaneous density is less than 10. So if it's less than 10 Hounsfield units, then it's a lipid-rich adenoma. You don't need to do anything else. If it's more than that, that's where you have to do further testing, and then it depends on what guidelines you follow. Traditionally, we do a adrenal CT with contrast to look at the washout, but some people are saying that's maybe falling out of favor. We should do MRI and we should do other kinds of imaging. Now, PET FDG would be more if you're thinking along the lines of malignancy. So adrenal CT with contrast, you want to look at the absolute and relative washouts, And that's been, from the 1990s, been the second line after your non-contrast CT. So basically, if you have an absolute washout of more than 60% or a relative washout of more than 40%, then you could say that you're confident that this is a adenoma, a non-malignant lesion. However, there's no evidence that is questioning that approach, saying that these cutoffs were based on old cohorts that were biased towards higher risk of malignancy. So they were not really true incidentalomas. These cutoffs were not based on those. Plus, they rarely change the management, high cost radiation, without changing the management in a significant portion of patients. And if you want to look at some of the FEO cases, if you have a FEO of less than 3 centimeters, 50% of them will have a high washout rate similar to a lipid-rich adenoma. So once you think about malignancy, one of the things that we fear the most is the ACC, adrenocortical carcinoma, and the risk is related to the size. So this is a typo, should be less than 0.5% if the size is less than 4 centimeters. Now, if you have a size between 4 and 6, that risk can go up to 5%, and then more than 1/3 of cases will be malignant ACC if the size is more than 6 centimeters, and hence why we say that if the size is more than 6 centimeters, you go for a surgical approach. And the second question is you want to ask, is this lesion metastatic or not? So it could be a malignant primary, as we said, ACC, or it could be a metastatic lesion, and we know that many different primary tumors can metastasize to the adrenals. So that can be seen in 1 to 3% of previously healthy patients. But if patients have known malignant disease, that could be up to 8% of the cases. And one of the hallmarks of ACC is that the imaging is quite characteristic. So you would have calcifications, necrosis, and hemorrhage, and quite often the spontaneous density on non-contrast CT is more than 20, and you might have also local invasion within large lymph nodes. So we dealt with the first part, malignant versus benign, radiological assessment. Now we want to talk about hormonal workup. Do you have to work up all the hormonal lines, or do we do it selectively? So we know that most adrenal glands are non-functional. If hypersecretion is present, it's usually a uni-hormonal excess. Rarely is it more than one hormone excess. So in hyperaldosteronism, you will see it in 1 to 4% of the cases of adrenal incidentalomas. Hypercortisolism in 5 to 12%. But be aware that there's this new entity called mild autonomous cortical secretion, MAX, which can be seen up to 30% of adrenal incidentalomas. And if you have, you can have catecholamine excess, i.e. pheochromocytomas, in about 1%. And if you have mixed hormones, so sudden increase of cortisol, sudden increase of your androgens, especially in a elderly female, you want to think about ACC. So what are the biochemical tests that we do? When you see this patient in your clinic, because of an incidentaloma found by CT, so you have to rule out pheochromocytoma in everyone, except if you have a CT, non-contrast CT, homogeneous lesion, showing with a spontaneous density of less than 10. And some people say even less than 20. Otherwise, you have to rule out pheochromocytoma even if the patient is asymptomatic, because we know that there's a 5 or 4 year delay between diagnosis and having the disease. We have to do the 1 milligram overnight DEXA suppression test. And what about the aldosterone-renin ratio? We only reserve it if the patient has hypertension or unexplained hypokalemia. So systematically, we don't do it. We just need to rule out the pheo and the hypercortisolism. Is there a sequence of testing which to do first? Now, preferably, one would want to rule out pheochromocytoma first, although it is very rare. Some reports have happened about a crisis because of the dexamethasone suppression test. Usually, it's extremely rare, but one would want to rule out pheo before doing the dexamethasone suppression test. So we don't measure catecholamines as we used to before. We look at the metabolites. So the metanephrines, they're more stable. Now, both plasma and 24-hour urinary-free methamphetamines can be used. Now here we don't have the privilege of ordering one or the other. Most of our hospitals will have only the urinary ones. Interfering medications can cause a lot of confusion and inertia. Should I stop this? Don't complicate it. Measure it while they're on the medication, because most of the medications, if they do anything, they will increase it slightly. And if you have a true pheochromocytoma, you'll have significantly elevated levels, 2 to 3 times the upper limit of normal, not a slight increase. If you have a slight increase, then you would want to reassess while stopping the offending or the causing medications. And let's not forget that some pheos are biochemically silent, and they will only be evident upon manipulation. And Professor Antoine Tabaran in France has studied this significantly and published also, if you want to look at his papers. So plasma versus urine, the differences are quite simple. So plasma is a one-time blood sample, whereas 24-hour urine, meticulous, the patient has to measure it, omit the first sample in the morning and then continue collecting in the special container, which contains an acid, and you have to tell them that, and it should be stored in a cool temperature after that. So having it done during the weekend and leaving it outside might damage the sample. In terms of sensitivity, the highest sensitivity is in the plasma methamphetamines. However, it has a lower specificity. So in some centers, they do the plasma first. If it's positive, they look at the urine. Now, one of the things that we have to also remind the patients, and this should be done by the labs, that ideally they should be in a supine position for 30 minutes at least, and the sample should be iced, because if they leave it until it's sent to a different lab outside the country, you might have degradation and falsely low. There's less interference with the plasma methamphetamines, more so with the urine. And in the MOH, we have only the urine methamphetamines. Second question, hypercortisolism. How do we test for that? The standard that we see, as we said, has to be done all patients, symptomatic or not. The gold standard is the 1 milligram overnight dexamethasone suppression test, but it has to be done properly. And I usually write down the sequence on a piece of paper to the patient, take it from this time to that time, and have to do it in the morning between 7 to 8 a.m. So if it's less than 50, completely normal. Between 51 to 138, gray zone, you might want to do other tests as well. Above 138, that's significant hypercortisolism. And then you want to establish if it's ACTH dependent or non-dependent, because it could be coming from the pituitary and with a coincidental adrenal incidentalloma. You don't want to miss that. So in reality, with the dexamethasone suppression test, there are lots of pitfalls, small, false positives and false negatives. So I'll give you an example. This happens a lot. You ask about the proper intake. Sometimes I went to bed early, I took it at 9 p.m., and I did the blood test at 7 or 8. So you will have a false reading. On medications that will increase or decrease the metabolism of dexamethasone. So on, for example, antiepileptics, that will affect that as well. On medications that will increase or decrease the cortisol binding globulin, such as estrogens. So you'll have falsely positive values when you do this suppression test. And being in any kind of physical stress or emotional stress can affect the CBG as well. That's why some centers do on the same sample in the morning, they measure the dexamethasone, the blood has to be in a certain range to be able to interpret the result. Other methods is the 24-hour urinary-free cortisol, so unaffected by the CBG. So in someone taking estrogen or OCPs, this will not be affected. However, it will miss the mild cases. The mild cases of MAX will be missed by this method. And you need to measure the 24-hour urine creatinine clearance to make sure that the sample is adequate, because sometimes they come to you with a container of only half a liter, and you ask yourself, is this an adequate sample or not? So measuring the 24-hour creatinine is also important. and it does not have any acid or the special container, so nothing, to worry about in terms of that. Late night salivary cortisol is a very interesting thing to do. It's very easy. However, it will also miss the mild cases. And it's not affected by medications, illnesses, because it measures the free cortisol and not the total cortisol. There's no effect of the CPG. Now, hyperaldosteronism, we said not in everyone, hypertension or hypokalemia. But you want to correct the hypokalemia first before measuring this pathway, aldosterone-renin. And it should be measured in the ambulatory position, ideally within the first 2 hours of wakening. Now, this is where confusion can arise. Hyperaldo, the hallmark of it is suppressed renin, inadequately suppressed renin. So if you have renin suppressed on medications, then that's even a higher likelihood that the patient has the disease, because most of the medications that we use in hypertension will raise your renin actually. So the same logic applies. Do not stop the medications and confuse yourself or the patient or cause a delay. Measure them while on the medications. If you have suppressed renin, that's an even stronger argument that the patient has hyperaldo. If the renin is not suppressed, that's when you want to stop certain medications and then retest again, or basically just refer to the endocrinologist in the hospital who will take care of this. So, once you have established that the patient has primary hyperaldo, you want to localize the disease. Is it to the right gland? Is it to the left? Is it in both? You can skip this part if the patient is young, because we know that the incidence of adenomas in this population is very young, is very minimal. So if you have an adenoma in a young patient with hyperaldo, then you could be certain that the patient has that disease in that gland if the contralateral gland is healthy. So age less than 35 and clear normality of the contralateral gland. Otherwise, adrenal venous sampling is a must. It's technically very difficult. We've tried it many times in different centers. Some have succeeded, some have not, some go abroad. And our friends from nuclear medicine will be helping us in the future. And with these newer agents, that will be, helping us bypass the need for AVS. When to operate, this is the most important question for the surgeons. So any pheochromocytoma should be operated if operable. And you want to ensure adequate alpha blockage before that. So all pheochromocytomas should be treated or removed surgically in an elective manner with a proper preparation. If you have unilateral hyperaldosteronism, that's also an indication for surgery. Unilateral ACTH-independent overt hypercortisolism, max is debatable. So American Association of Endocrine Surgeons are pushing and recommend doing this surgery for max. Other guidelines are less, insisting in their recommendations, but something to discuss with the patient. Bilateral disease is also an area that can be debated and discussed with the patient. If you have bilateral disease, resection of the larger nodule can help, but there is a higher risk of recurrence in some series up to 60%. So you want to ask and discuss this with the patient if there's something feasible. If you have suspicious imaging, and if we have a size more than 6 centimeters or growth that is rapid. And obviously the benign lesions, if you have mechanical compressive symptoms, same logical applies to even the thyroid if you have benign disease, but compressive symptoms. So if you want to look at it based on the size, less than 4 centimeters, benign imaging, no surgery. Between 4 and 6 centimeters, MDT discussion, looking at other features, how rapid is it growing. Above 6 centimeters, we said that the prevalence of ACC is very high in this group. Any functional tumor should be a candidate for surgery. Medical treatment is inferior to surgical treatment in these patients. What about the follow-up intervals? The patient has a disease and not to be operated, but you want to follow up. How often and how do you follow up? So we said most non-functional adrenal adenomas do not grow. The minority will. So 10% will grow 1 centimeter or more over the course of 2 to 5 years. And there is no need for further imaging if size is less than 4 centimeters, spontaneous density is less than 10 Hounsfield units, and some are even pushing for a higher cutoff, and it's non-functional. The Europeans say, regardless of the size.
Excuse me, Dr. Ahmed, 1 minute, please.
Okay. So, Europeans say, regardless of the size, if you have a clear benign disease by radiology, less than 10 Hounsfield units, you don't even need to do a follow-up imaging. If it's less than 4 centimeters, non-functional, between 10 and 20 Hounsfield units, then you want to do follow-up imaging in 12 months. If between 4 and 6, regardless of the Hounsfield, follow-up imaging in about 6 months. So take-home message from this talk is that all adrenal incidentallomas must be evaluated for 2 things: risk of malignancy and hypersecretion of hormones. And you want to just memorize that you have to rule out FEO in everyone except if the spontaneous density is less than 10, homogeneous lesion, and hypercortisolism. And with that, I end, and thank you for your time.
Thank you, Dr. Ahmed, for your excellent presentation. Now, Dr. Abdulatif al-Turki, he's going to present for us a non-functioning adenoma to stay or to go. He's a consultant urology in Amiri Hospital, urology in Amiri Hospital, and he did his residency in Canada in Manitoba University in 2003, and he was followed by a fellowship in the minimal invasive surgery in McMaster in 2004, and he's the founder of Kuwait Urology Residency Program and previous director, past chair of the accreditation in KIMS. Welcome, Dr. Abdulatif.
Thank you very much for this introduction. Thank you very much for inviting me, and specifically, thank you, Dr. Ahmed. You made my life easy. There's a lot of repetition from surgical and medical, but I think we have to look at it from different ways, and I hope I add to you've steal the whole thing, so that's fine. You would have passed as a surgeon easy, no problem. So I'll start. I think the fundamental question when we talk about whether the non-functional, I'm going to talk mostly about non-functional adrenal incidentallomas, to stay or to go. I think that's the fundamental question. That's when they find it on your imaging. That's what the patient asks you. That's what the relatives and the physicians. So I have no disclosures. I'll start with a case. This is a 20-year-old female known with hypothyroidism, congenital adrenal hyperplasia, and ambiguous genitalia. Sorry, I brought the whole spectrum of endocrine. Presented with episodic hypertension or with occipital headaches, weight gain, irregular menses. Sorry, weight gain, irregular menses, every female have that, but I think we're related with the condition. So on the ultrasound, they found a left adrenal mass, 8/7. Sorry, this is the CT. So it's plain, thank you. Okay, so this is the mass we see. There's a calcification, there's enhancement, there's also multiple areas of necrosis and a fairly heterogeneous, and thank God the kidney was okay. Hounsfield urine of 4.7, washout absolute 14%, relative 8%. So this is in a different plane. That's to see it. It's a good sized mass. It's bigger than the kidney. So in a 20-year-old female. So the question, to stay or to go? So this is my outline. I'll start with the scope of incidentallomas. I think Dr. Ahmed did a great job. Essential questions: functional, is it malignant, is it growing, decision as per guidelines, and special cases. So this is, when we say incidentallomas, everybody actually runs it down as something simple. But it is not insignificant. Any lesion above 1 centimeter, as the definition says, it could be any of the pyramid of these conditions. So it's very important to pay attention to this, and initial presentation should be worked up properly. And then this is a disease of modern technology. We do a lot of imaging, and actually we're finding the same with the kidney cancer as well. There's so many incidentalomas, but that's not similar to this. But we tend to find more and more, up to 5% the prevalence, and from autopsy studies up to 9 to 10%. So the three important questions: is it functional? And I think Dr. Ahmed did a great job. Is it malignant or growing? Each one has its own implications. So is it malignant? When we see, hang on, we see a lesion like this. This is a fairly typical of an adenoma. The CT becoming more and more the gold standard for diagnosing, and then what are the criteria to do this with. So what do we use? We use the Hansfield unit, the CT attenuation, the size, the homogeneity on CT, lipid content, and the border regularity. So the Hansfield, anything below 10 on enhanced CT, it signifies an adenoma. The sensitivity of this cutoff is nearly 100%. Similar test characteristics being confirmed purely by surgical series. So basically it corresponds well. The sensitivity of getting a benign lesion is fairly high. However, the specificity and sensitivity for malignancy is not as good. What about the size? Size actually does matter in this. There's a strong correlation between the size in a series of over 2,000 cases. The bigger the size, the more chance of malignancy. So we can reach up to nearly 20% if it's above 6 centimeters. So large masses, usually benign on imaging features, but you have to actually stratify these cases and review them, and also no malignancy if the Hansfield units is less than 10 on non-contrast CT, regardless of the lesion size. What about the washout? I think Dr. Ahmed brought the washout clearly. However, still it's not the best test. It's important to differentiate the lipid-poor adenomas from other adrenal lesions, but however, it's not the most sensitive. Even with, it gives you, it helps the decision-making, but it does not mitigate or it gives you an absolute indication for malignancy or not. So when we see this, so I think just to concentrate, it's a busy slide, but I think over 60%, or this is absolute and relative, it's not as an essential tool for us to rely on to make a decision, but it helps. I think when you have a large washout, this actually signifies the being benign of nature. But if it's low or it's not as high, then this will give you an indication to investigate more or to use it as a tool to make your case. So what about the MRI? MRI actually helps. Also, it's an excellent tool for detecting lipid-rich lesions, but I think CT usually helps. However, we can use MRI in certain patients who are, when we have indeterminate, or to avoid radiation on contrast on young, pregnant, and contrast allergy patients. So the big question, is it growing? I think even if it's benign, I think this is when we differ with the physicians, Dr. Ahmed. I think if it's showing any growth, not in any pace, I think growth, there's different, each one will give you a different speed of growth or the size of growth. But I think usually, if you have a lesion, I think you need to follow it up. I think there's a lot of, we'll look at the guidelines, and some people don't say the new guidelines do not follow up, but I think if you have a lesion, I think it's important to follow it up. The recent European an increase over 20% tumor diameter, at least 5 millimeter in growth, should be considered clinically concerning. But I think they have different rates of growth. If you have these patients, and even if they're non-functional, I think just imaging on a routine basis will help. So my question again, so let's go one by one. So if it's homogeneous, less than 10 Hounsfield units, the Korean, I use the Korean guidelines, comprehensive evaluation, no definite cutoff value for excluding malignancy, but if it's small, you just watch. Less than 4 centimeter for the American Association of Endocrine Surgeons, no routine follow-up, and then the Europeans Society of Endocrine, no additional imaging, irrespective of size. What about if it's non-functioning with 11 to 20? That's a different category. I think they're trying to jam them together, Ahmed, the 10 and up to 20 on enhanced, and size less than 4. The Korean Society also, they will watch them actually closely initially, and then they spread up the follow-up. The Americans, 1 repeated image, 6 to 12 months, confer stability, and then the European, if it's benign, no further imaging, imaging after 1 year, unenhanced, and an alternative approach. Okay, so what about if it's homogeneous, more than 20, or heterogeneous on enhanced with tumor 4 centimeter or more? So this is will be followed by the Korean Association, but if it continues to do, if it enlarges by centimeter, this is coming out. The American should be, once they say it's malignancy is considered, this is coming out, and the European immediate surgery will be the management of choice. What about the indeterminate lesions, which when you have more than 4 centimeter with unenhanced and less than 4 with unenhanced, but over 20 Hounsfield, or the tumor size less than 4 with heterogeneous appearance. So this is important of the MDT, which I think we have to do more and more with our colleagues. And I think on an individual basis, should be decided. And a lot of us, when we have these cases, I think we discuss them with the patients as well. We involve the patient in the decision making, especially the young, healthy. We usually don't keep them because some of them don't want to be following up, don't want to be being on the loop for a long time, and some of these will come out. What about in certain population? We do recommend surgery if it's indeterminate in children, adolescents, pregnant women, and adults less than 40. So I think that's also goes into the MDT and actually involving patients in this decision, or the patient parents. What about the myelipomas and cysts? We should not be doing these unless they have symptoms of mass effect, or if they indeterminate imaging, or prior hemorrhage, or mass effect, or substantial growth on interval imaging. This is a huge, this is a 26-year-old young lady with a huge cyst. So we did this robotically. It was removed, and it was fairly benign, and removed one limb of the adrenal with it, with the other limb kept. Back to our case. So just to remind you, whoever was asleep, so you can check it again. So this is the big mass, according to what we said, big mass, Hounsfield 47, or SHAD 14 absolute, 8% relative, heterogeneous, soft tissue calcification. So, and we checked it, non-functioning. So we made the decision to go, and it's out. And we did this laparoscopically. It's adrenal cortical adenoma, oncocytic type. So I think still this is a challenge. We have not answered all the questions, especially from surgical point of view. I think it's from medical point of view to work it up is either yes or no, and sometimes actually we have to wait. It takes time for it to come into action or come into life. And the worst thing which comes to life is on table. We have these episodes of pheochromocytoma like or hypertension crises on the table with induction and all this. But these are very rare. But I think the surgical question is still not answered completely. But I think MDT, multiple, so we cannot standardize protocol for assessment, many controversies. CT can help. I think this is a major issue, and I think we need to develop some kind of a team approach to all cases. So because most of the lesions are benign, most functional are mild, and most suspicious ones are not declared immediately. I think you have to wait, hence the follow-up. And I think guidelines can guide your decision, but every patient is different. Thank you.
Thank you, Dr. Abdulatif, for this elegant presentation.
Yes, thank you, Dr. Al-Dwaji, and I will introduce next two speakers, Ki Jung from Assam Medical Center. Next speaker is Professor Taeyeon Song. Now she is head of Division of Endocrine Surgery, Division of Endocrine Surgery, Department of Surgery, Assam Medical Center. She will talk about the robotic versus laparoscopic adrenalectomy, any privileges of each. And Professor Song, please.
Thank you very much for the kind introduction. Good afternoon, dear ladies and gentlemen. I am so honored to be here and felt so much kindness already. First of all, Alf Mabruk for the grand opening of the first Kuwait Endocrine Surgery Symposium. And I truly appreciate this valuable invitation. This is actually my third time visiting Kuwait, thanks to Dr. Ali, everyone, and especially Dr. Ali and Dr. Shaima, who are now president and vice president of this society. So I'll start now. I have nothing to disclose. In this session, my presentation will flow in this order. We all know that for the minimally invasive adrenalectomy, laparoscopic transperitoneal approach was first introduced and became sort of the standard procedure for most of the functional adrenal disease. Then came the laparoscopy retroperitoneal. Recently, but fast advancing, robotic transperitoneal and retroperitoneal approach have emerged. For these minimally invasive adrenalectomies, most of the functional diseases like these are good candidates. In Assam Medical Center where I work, endocrine surgery division perform about 200 adrenalectomies per year. Most of them are by a retroperitoneal posterior approach, followed by transperitoneal. Since I do most of the cases by a retroperitoneal approach, I have focused on the differences between the RAPA and robot in retroperitoneal way. Among the retroperitoneal adrenalectomy cases, about half are performed by robotic system and the rest are by a laparoscopic way. Now let's look over how the procedures are somewhat different. Typical positioning of the patient is in prone jackknife. For the laparoscopic RPA, we need at least 3 ports incisions. For the robotic RPA, we could use 3 ports incision. However, I developed 2-port incision technique with using multi-glove device, which allows us to use 3 arms and extra if needed, even with 2 ports. And with the robotic system, even single-port incision adrenalectomy is available now. The part that made us possible to reduce the number of port incision in robotic system is mainly dedicated to the structural difference in the acting instruments. For laparoscopic ones, the instruments are straight. For robotic ones, the instruments have so-called wrist area that can make a 90-degree angulation, a movement, and swing 360 degree. Other differences include that for laparoscopy RPA, you need an assistant to hold the camera and have to collaborate together to focus on the action field. When in robotic system, you have the control of camera movement by yourself. Now let's go over a few cases and actually feel the differences. First, since this is the retroperitoneal presentation, the patient is in prone position. To start, we start with opening the gyrus fascia. For the left side, usually the kidney is seen on the left lower corner. After dissecting further on the right side of the kidney, we encounter the left adrenal vein. For the right side, usually the kidney is on the right lower corner. This video clip is laparoscopy RPA dissecting left side 6 centimeter incidentaloma. You can see that the instruments are straight and colliding. Going deeper on the left side is needed to mobilize the kidney and approach to the adrenal tumor. Here, the axis of the movement is made from the outside of the abdomen, away from the surgical field. This is a video performing laparoscopy RPA on the right side, pheochromocytoma. You can see that the straight instruments are crossing each other with discomfort. In this case, tumor was embedded on the liver surface, but not invading. And delivering the tumor with a straight instrument was not that easy. And you can see that the start of the adrenal vein on the right side is very short. And with laparoscopy approach, the vein has to be in the right position for the right ligation using that straight clip instrument. Now this is a robotic one, robotic RPA video of a left side pheochromocytoma. You can see that the movement of instruments are close to the tumor, and the main movement axis is made at the point of dissecting area. So you can see that applying clip is much easier here. In small space, still a wide range of movement. For this case, tumor was deeply located, somewhat towards the anterior abdomen. So if this was performed by a laparoscopy approach, I probably would have made a long face and be stressed out. There is the space. This is a laparoscopy RPA video on the right side, Cushing syndrome. By looking at the screen, you can tell that the main axis of instruments are at the point of dissection, which allows us to perform much finer dissection compared to the laparoscopy ones. You can directly see the 90-angle degree angulation of the energy device on my right hand right now. As you can see, the stork, now you're going to see the stork of the adrenal vein, is very short. And delivering the tumor with the straight instruments would have been difficult. And this is you're going to see right after that, the final view after dissecting the tumor right there. It was very high, very deep, so I didn't struggle because I guess I used a robotic system. And now the published literatures. This paper was published in 2022 from Europe, comparing the results of robotic versus laparoscopy adrenalectomy. However, this study only focused on transperitoneal way. Here, the results show that robotic approach presented less complications rates and less duration of hospital stay. Several other papers also stated that robotic approach was safe, feasible in the field of transperitoneal approaches. In 2021, an article was published from Italy reviewing 40 published literatures. This study included papers that dealt with transperitoneal and also retroperitoneal ones. In conclusion, they presented that complications, operative time, hospital stay were comparable between two approaches. For bilateral disease, along with cases that needed sparing adrenal tissue, obese patients, or having large tumors, robotic was more beneficial. However, money is always the issue with the robotic system. This paper was published this year, and I had the privilege of getting involved in this study. Data from 46 international centers from 20 different countries were included to compare robotic versus laparoscopy adrenalectomy for pheochromocytoma. Transperitoneal was 65% and retroperitoneal 35%. The main conclusion was that two approaches were comparable in most of the well-known surgical outcomes. However, even though we did propensity score matching, the robotic portion was only 10%. Since Asan, where I work, does 90% of the adrenal cases retroperitoneally, we compared between the robotic retroperitoneal and laparoscopic retroperitoneal. At the study period, however, robotic adrenalectomy experience for me was less than 1 year. When most of the typical variables were compared, there was no differences regarding age, gender, BMI, type of disease, except the operation time, which it was longer in the robotic ones. The reason was that the patient cart docking time in the early phase took quite long and needed learning curve because no one taught me how to use the robotic system by then. So besides that factor, let's look at the factors that actually prolong the operation time. In laparoscopy cases, male gender, high BMI, large tumor, and pheochromocytoma, which might be related to the tumor size, because pheochromocytoma is usually larger, were the associated factors that prolong the operation time. But for the robotic cases, only larger tumor size and pheochromocytoma were the factors associated with prolonged operation time. There was a linear correlation between the tumor size and operation time. The tumor size, mean tumor size was 5.5 centimeter in our study, and when the tumor size was larger than that, actually the operation time got shorter in robotic cases. And recently, but not published yet, we found out that the abdominal circumference factor was more associated with longer operation time than the BMI factor. So through this study, we concluded that if the patient is male, obese, and has a larger tumor, robotic RPA with angulation movement might be a better choice of approach than laparoscopic way. But recently I had an experience. The robotic approach is not an answer to all the obese patients. Adequate space for gas infusion, amount of perirenal or periadrenal fat, which might block the view, should be accounted for. Finally, I'll wrap it up. We're already late. Main laparoscopic RPA advantages compared to open first are smaller incision, reduced postoperative pain, a faster recovery time, and lower complication rates. Well, with the robotic ones, the advantages are all of the laparoscopic advantages. In addition to that, enhanced precision with closer axis and angular movement with less incision. So if you're planning minimally invasive adrenalectomy for most of the functional diseases, for larger tumor, obese patient, or male, consider performing robotic adrenalectomy rather than with a laparoscopic approach. But there is always not a final answer to everything, so one could be better than the other in many different cases. Well, thank you, and shukran jazilan for listening.
Thank you, Professor Song, especially for timekeeping, and we'll move to next speaker. So let me introduce next speaker, Dr. Shaima Dashiri. And Dr. Dashiri is a specialist general and endocrine oncosurgery at Amiri Hospital, Kuwait. And Dr. Dashiri also had 2 years of fellowship in Asan Medical Center with me and Professor Song. It was a very good time. And she also served as a vice president of this society. She will talk about the lymphadenectomy in adrenal cancer surgery and its specific groups. So Dr. Dashiri, please.
For the warm introduction in a very cold room. Today we were freezing. And I know it's the end of the day, everyone wants to go home, but allow me to say this. Being part of the organizing committee of this first endocrine surgery in Kuwait, I'm genuinely proud of what this meeting represents for our community. It's a real step forward in endocrine surgery. And I would like to thank Dr. Ali Sayed for the huge amount of efforts he put into this conference, and also for the healthy amount of stress he put on all of us to make sure that everything was organized perfectly. Of course, a warm thank you to our inviting speakers and our local speakers for accepting our invitation and being part of this important milestones to us. Let me not take more of your time and start my talk. I'm talking about lymphadenectomy in adrenal cancer. Should we do it? Should we not? And if we do, which lymph nodes actually matter? I can jump from my topic to the last slide, the recommendations, but I don't think it's that simple. To decide whether to follow the recommendation or not, we need to know what's the evidence behind it, how it was built, and the gaps and inconsistencies in the findings. To begin with, let me talk about adrenal cancer. Adrenal cancer themselves are rare and aggressive tumors, fall into three main categories: cortical cancers, the adrenal cortical carcinomas, medullary pheochromocytomas, and paragangliomas, and metastases from another primary source. Talking about lymphadenectomy, the focus shifts naturally to adrenal cortical carcinoma because this is the tumor where lymph nodes involvement has a clear staging and a prognosis implication. Adrenal cortical carcinoma has an incidence rate of 0.5 to 2 cases per million per year with a bimodal peak pattern, one peak early in childhood before the age of 5 years, and the other peak is in the 5th decade with a slightly female predominance. But the real challenge is that unfortunately 60 to 80% of patients when they present late with advanced disease, either stage 3 locally advanced or stage 4 metastatic disease. In terms of prognosis, overall survivors, unfortunately it carries poor long survival. The overall 5-year survival is around 30 to 40%. And it ranges widely. In stage 1 with complete resection, it can reach 60 to 80%, where it can fall to less than 15% in stage 4. Even with complete resection, recurrence rates remain high. It's reported to be between 60 to 70%, and most of the recurrence happen within 2 years with a median survival of 28 months. Nodal involvement is documented to be roughly around 15 to 25%, and under NSAT staging system, which is the tumor staging system specifically for ACC patient adopted worldwide, says that any lymph node involvement automatically shift the stage to stage 3 regardless of the tumor size. And as we said, in the overall survival, the upstaging of the tumor has a major impact on overall survival and prognosis. The histologic features, including WACE score incorporating the mitotic rate, the atypia, necrosis, capsular and vascular invasion, along with the Ki67, tumor rupture, margin status, all influence the behavior and prognosis. But among all these features, lymph node involvement stand out as the strongest indicator for ACC prognosis. Now, the question is, if lymph nodes metastasis is involved, what should we do about it? When I looked in the literature, this is what I found. Unfortunately, once you start looking in the literature, you will quickly realize how scarce and limit the data that we have. The first problem is that the tumor is very rare. Most centers see fewer than 5 cases per year, which limits the experience and makes it difficult to conduct proper prospective trials. And because most of the cases preoperatively lymph node metastasis is often missed, most series don't even include systematic lymph node assessment. Now, most of the studies that we have are also retrospective, with single center, highly heterogeneous, different technical approach, different extent of lymph node metastasis, and the long-term follow-up is even inconsistent. On top of that, the literature is divided into 2 very different types of evidence: anatomical, where they study the normal adrenal glands, and clinical, where they study the lymphatic drainage in large tumors with distorted anatomies. The anatomical studies are, as I said, most of them are cadaveric dissection or lymphoangiographic mapping, studying lymphatic drainage in normal adrenal glands. A recent meta-analysis identified around 18 such anatomical papers where they describe rather orderly lymphatic drainage with separate right and left lymphatic flow, and they supported the concept of compartmentalization, where the adrenal gland is divided into superior, middle, and inferior, and further into anterior and posterior. On the other hand, we have the clinical data. The same systematic review identified only 4 true clinical mapping, where they describe where exactly the positive lymph nodes happen in ACC patients. And there were around 20 to 21 series describe the lymph node dissection, and they mentioned that only 20% of patients underwent lymph node dissection. So it's not surprising that the data from both studies don't always align, because as we said, anatomical studies work on a normal adrenal gland, showing that the lymph node extension usually is neat and predictable. And we have the clinical studies where they study more aggressive tumor with aggressive behavior and distorted anatomy, shows that nodal involvement usually is inconsistent and less predictable. So let's see the lymphatic drainage from the anatomical study perspective of a few. I don't know if it's clear to you in the picture. If you see the light green shaded oval shapes present the right adrenal lymphatic drainage, and the dark green represent the left lymphatic drainage. Anatomical studies found in the beginning that there is asymmetry between right and left lymphatic drainage. Right mostly drains to the paracaval nodes as a primary basin. Second, it drains to intra-aortocaval. Only very few studies found that some of the drainage goes to the right renal hilum, and it was inconsistent. And the reason for that, the right adrenal gland has very short efferent lymphatic channel that usually drains directly to the IVC. On the other hand, the left adrenal usually drains to the para-aortic node, secondly to the left renal hilum, and some occasional drainage to superior mesenteric node and celiac axis. The most important thing in the anatomical studies that they never showed contralateral drainage, so the right side never drained to the left and the left never drained to the right. However, in the clinical studies, if you see again the light yellow color, it represents the right adrenal lymphatic drainage, and the dark yellow is the left lymphatic drainage. In the right, still paracaval remained the most basin to receive the metastasis. However, it showed also para-aortic involvement in 20 to 30%, which is a thing that never anatomical studies showed, a contralateral drainage. It showed also that the renal hilum was involved more than the inter-aortocaval. Also, it reported there is a mediastinal metastasis in 5 to 10% of patients, which represent a skip metastasis. In the left adrenal lymphatic drainage, para-aortic received the most involvement. Then again, contralateral drainage to paracaval, renal hilum, again superior mesenteric plexus, and mediastinal as a skip lesion. So according to the finding they found in this meta-analysis, they suggested area of resection. If you see the red, represent the area they suggested for right adrenal cancer, that at least periadrenal, perihinal, pericaval, and anteroaortic caval should be resected. And left adrenal mass, periadrenal, perihilar, and para-aortic and anteroaortic caval should be resected. But these are only recommendations, not a true guidelines. Now, that one was in terms of the lymphatic drainage. Here I will summarize to you what the clinical studies actually said about lymphadenectomy and its outcome. First, lymph node involvement was documented anywhere between 8 to 55%, so you can see it ranges widely. Yet, lymph node dissection was performed only in 20% of cases. Second, survival benefit was really related to the stage of the disease. So it showed potential benefit when it was done in early stages, from stage 1 to stage 3. But when you combine all stages together, including stage 4, the benefit became non-significant. The safety profile in general is reassuring. There is no difference between the group of lymph node dissection and no lymph node dissection in terms of hospital stay, and the mortality rate for both groups is very low, less than 3%. Also, it showed potential benefit in disease-free survival, and it might reduce local recurrence rate in some studies. Still, the impact on distant metastasis is not clear, because they found that hematogenesis spread and distant metastasis happen with lymph node involvement or without lymph node involvement. So the current argument really sits currently on these things. On one hand, we have a potential benefit with lymph node dissection and a clear benefit with staging. On the other hand, the data that we have is only limited and we lack level 1 data. And again, as I said, hematogenesis spread happens with or without lymph node dissection. So let's see what's the recommendations, opinion, and how they evolved over time. The ESES and INSAT, which I said previously, they are ACC focused staging system. Early in the 2012 and 2015, they did not have formal guidelines, but yet their opinion was focusing on staging benefit and standardizing prognosis. That changed in 2018 when INSAT formal guidelines was published to recommend routine local regional lymphadenectomy for suspected or proven ACC. They recommended to excise or to dissect at least the periadrenal, renal high lymph nodes and remove all suspicious lymph nodes. Again, they emphasized on the weakness of the evidence that they have. In 2020, they reinforced that ACC should be done by experts who are performing more often adrenal surgeries and again acknowledging the limited data. Meanwhile, until 2023, the NCCN, which is non-ACC focused guidelines, they are still conservative. They are recommending just excision of lymph nodes that are suspicious or enlarged during surgery, and yet no routine lymphadenectomy are recommended by them. So, as you see from the recommendation, there is a full agreement between all guidelines to excise at least any suspected or enlarged lymph node, but yet the difference comes when we recommend the local regional lymph node. As I said, that NCCN is not ACC focused guidelines. The ESES and INSAT are focused. Now, instead of me saying my personal opinion, because I'm not considered yet doing a lot of adrenal cancer surgeries, I asked my colleagues who are expert in the field and performing a lot of adrenal surgeries, of course my mentor in Asan Medical Center, and I also checked the literature. I could see that the general practice here everywhere among experts, that whenever there is ACC suspected lesion or proved, usually an effort is put to excise the adrenal mass along with the periadrenal fat and the perinephric fat. So it's in a block resection of the adrenal mass with the periadrenal and perihilar fat. This is just a dessert slide just to complete the picture. If lymphadenectomy is going to happen, which approach you would proceed with? And I believe Professor Tay mentioned some of the advantage of robot over laparoscopy, but we know in adrenal cancer that still the gold standard approach is open approach, because it should be done safely with wide view and anatomical respect. But yet, if we have a small tumor less than 6 centimeter, no evidence of local invasions in the images, and we have expert surgeons who are performing a lot of adrenalectomies. Some of them are performing with laparoscopic approach. But the robotic surgery is increasingly being adopted as a minimal invasive and replacing the laparoscopic approach, because it is combining all the benefit of laparoscopy with better vision and better articulation of instruments. So as a Professor Tayon said, in obese patients, they even noticed that sometimes robotic procedure is better than open surgery to gain exposure and in a block resection. So what's the bottom line for lymphadenectomy and adrenal cancer? Again, we don't have the answer, definite answer yet, but what we know is our evidence is still limited. All our studies that we have are retrospective studies. We don't have a proper preoperative assessment of lymph node involvement, but the staging benefit is clear in lymphadenectomy, so still all guidelines are recommending the lymph node excision for staging benefit, and they usually recommend at least 5 to 6 lymph nodes to be excised during the procedure for better staging. Technique matters, so it should be done with expert and it should be done safely with respect to anatomy. And until we have a proper clinical trials, I think we should follow the ACC specific guidelines by doing the maximum that we can do for ACC patients. That's the end of my slide. Thank you so much.
Thank you, Dr. Dashti, and I would like to invite four speakers to the podium. And Dr. Aldoai and I agreed to make it a little bit short this time because of time delay. So until we are waiting for the questions from the audience. And Dr. Aldoai, is there any questions online?
Yes, there is a question for Dr. Ahmed. So how you do the approach as an incendioloma that is non-functional and having a border image HU of 12 or 18 with the stable size, but the patient reported subtle symptoms like fatigue or episodic hypertension. Do you think guidelines underestimate the role of surgery initiation in these almost functional tumors?
Okay, so if you determine that the nodule is non-functional from the beginning, the guidelines say you don't need to reassess if there's hypersecretion later on unless there's change in the clinical presentation of the patient. So this patient, for example, even if the initial testing revealed a non-functional mass, but the patient comes later complaining of lethargy, tiredness, maybe gaining some weight, which is very common and non-specific, I would still reassess and assess if there is hypersecretion at that stage. Now, could be max, mild autonomous cortisol secretion, which is very common, about 30% of the patient will have it, and it is considered for surgery in an MDT meeting if the patient agrees to the risks and benefits, and this is discussed with the surgeon. So yes, the guidelines can be underestimating in certain situations, and that's why I agree with what my colleague Dr. Turki said, that MDTs are a must for these patients, as guidelines will not be sufficient for most cases.
Okay, thank you. There is another question for Professor T. So do you think, is there a role for a partial adrenectomy to some benign adrenal lesions?
I have a lecture about partial, but that's surgical thing. For benign, we could go with the partial. There are certain papers that has been published, but usually the reason that we do surgical treatment for, say, that looks benign, that is to do the diagnosis, and if it's unilateral, I personally, under my experience, I don't prefer doing partial or subtotal or sparing because what if it comes out something else? What if it's not benign? Then probably we will have to go in again. So if it's not definite benign, you're just doing it to remove it, maybe it's a large tumor, but it's a definite benign, then we might leave some adrenal tissues. But if not, I go for total.
Yes, questions from floor.
Thank you. My question for Dr. Dashti. Regarding lymph node for adrenal cancer, in other cancer like breast, there is de-escalating lymph node dissection because of other chemotherapy or target therapy. What about adrenal cancer? Do you have any modality which can spare the patient of lymph node dissection in that area?
Thank you, Prof. Subhi, for the question. To be honest, when I was looking in the literature, they did not mention anything specific that can help in downgrading the lymphadenectomy because the efforts are made in the opposite direction actually to maximize the lymph node dissection. The thing only that is holding us from the dissection is the practical difficulty in dissection. But I think I came across some of the studies that are using ICG, as mentioned before, that it can give us a better picture of the involvement of the lymph nodes during the surgery. I don't know if it's going to be more adopted or not, but some of the surgeons are using it.
Can I just add to this, Professor? Thank you for the question. This is a very rare disease, but at the same time, it's a very aggressive disease, and it's actually one of the most aggressive tumors we have. To be honest, we don't even, it's not just the lymph nodes. I think one thing Dr. Shema didn't touch on is we take everything in the way. I think the spleen comes out, the kidney, can be that aggressive. Sometimes part of the liver as well. So if it's on the right side. So it's very, very aggressive. And I think lymph nodes, anything suspicious, you need to clean that area completely. And even with the toxic chemo they give, the chemo itself is very toxic as well, maintained. So I think if it's not proven because there's not a lot of data. I think if you have something suspicious in the way, everything you should clean the whole area as much as you can, because I think that's probably the best chance. Even with chemo, these young guys, they don't do very well with this because of the toxicity of the chemo itself.
I have another question for Professor Tai. About you mentioned you do like 200 adrenal per year, so in your center in Korea, so that's very high volume. How many center in Korea they are doing high volume adrenal, or you are the only center doing it, or how you got this number? Interesting for me too.
In Korea, and especially in Seoul, there is about 5 large institutions, so to say. And Asan is one of the biggest, I guess. And for the adrenal cases, I really got involved to it since year 2016, and a lot of patients has been referred to our hospital. So we are doing the most of the adrenalectomy, and mainly in the endocrine division. And for the other institutions that are called large, probably the most are doing about 100 or maybe 150, but most of them are much less than that.
Congratulations, very, very good number. Thank you.
Thank you.
I would like to commend all the speakers for excellent presentation and very clear presentation. I have a question for the surgeons. If you have a patient with the syndrome like Van Hippel-Lindau or Amiens syndrome with the bilateral pheochromocytoma who previously had adrenalectomy, now had a contralateral lesion, do you do cortical sparing adrenalectomy, and any tips how to do it, and what do you tell the patient pre-op? Any consideration if it's for the right side and if it's for the left side? Is there any consideration for those surgical approach for those patients?
Actually, I have the talk tomorrow with the sparing one. To make it short, if it's hereditary diseases, I would discuss with the patient and the endocrinologist and go for partial on one side usually, because under my experience, I encounter one side is larger and one side is smaller. So I'll go for the partial, or I usually use the term adrenal sparing. So I'll do adrenal sparing on the side that has a smaller tumor, and go in and do that part first and see whether there is really normal adrenal tissue. So if it's possible to do the sparing, then I'll do that. And whether it's right or left, I go for the smaller one and the partial. And the rest, like how I do it, I'll be presenting it tomorrow morning.
We had a few cases like this as well. And I think, first of all, I think you need to talk to the patient. Even if you're planning partial, there's a chance you might remove it all. I mean, if you want to remove both sides in one session, that's been done, and we've done it. But I think it's very important to counsel the patient and prepare them for the, all adrenal out part of the adrenal. So I think one topic which we've been noticing lately, and actually it's a good discussion, but hopefully we'll do it tomorrow, is even if you remove partial and you remove another one, or you remove one, there is subclinical conditions as well which can arise. I think one thing we faced, we removed one adrenal from one patient and we had a subclinical cushion, and actually the patient was suppressed completely. So basically with a normal looking, not normal functioning, contralateral. So I think it's very important to counsel the patient, and you plan whether to do a partial on the smaller one and then go for the bigger one. But if you're planning to go in, you have to counsel the patient up front, especially now with the medical legal stuff, that you might plan to remove both. But I think you have to plan this before you start. If you leave a limb and you do a partial adrenectomy on one and you remove the bigger one, there's no guarantee that this will not recur. I think that's something, even if you do a partial, you have to tell the patient, this might come back. You might need another surgery. And if something happens, you move both. So I think all possibilities should be on the table for the patient. But you can do it in one session.
One last question from
I would like to ask the surgeons also, and I need to hear an answer from all of you. In which situation you consent the patient for nephrectomy while you're going in for adrenal whatever lesion, now whether benign or malignant? So do you take consent for possible nephrectomy, even in benign cases, tiny one, small one, you have a doubt of something else, or it's only in cancer patient or patient with a huge tumor that you're doubting that I may not be able to take it alone and I may take the kidney with it? So do you consent all of them for nephrectomy or not? So if I can hear from all of you. Thank you.
I can tell you that Dr. Abdul Latif will consent every patient for nephrectomy.
Not true, not true.
No, I'm joking, I'm joking.
Well, in Korea, actually, I don't think my residents or fellows are getting consent about nephrectomy in every case. Never, I don't think so. And usually for large ones, I could mention it to the patients, sort of, I might be touching other organs, but no, not in my paper. I don't do that. To tell you frankly, I don't do that.
For being a urologist, we love the kidneys, but I think large tumors, we tell them we might remove the kidney, we might remove part of the kidney. I think you have to be fair, you don't know. Even actually on the right side, if it's a large tumor, we'll tell them we might remove part of the liver. If it's involving, it's difficult to tell, especially with a large, like the young lady, this is very suspicious for cancer, so you need to give them the best treatment. So it's difficult sometimes, but as a rule, when we consent the patients, large tumors, heterogeneous, and we think there's a mass effect and you cannot delineate the plane between the mass and the kidney, I think it's fair to consent them for that, and they should understand before they go in. I think it's very important to be really truthful, straightforward, and you have to tell them how you think. You cannot tell them afterward. You have to tell them before you start, and I think it's a good exercise.
No, I definitely agree with Dr. Abdul Latif, but as a young surgeon, I have low threshold to consent patient for any possible complications. So it's like when I'm doing thyroid, we always tell the patient there might be an injury, iatrogenic injury for any nearby structure. So even in adrenal surgery, we might suspect that we might have iatrogenic injury to the kidney. So I prefer to usually inform the patient.
Thanks everybody for the presentations, and thanks for the discussion, and also thanks Dr. Aldwai for co-chairing. Okay,
Thank you so
like
much.
to close this session.
Don't leave the stage. We'll take a photo all together, please. The moderator with the speakers. And I would like to present where is the certificate for our moderators? Professor Chung, thank you so much. Let's take a photo together. My colleague, my sister, one of the most precious people in my career, Dr. Sandis Led'ay, our endocrinologist, she keeps referring the patients for me, so please continue. Thank you very much. So this concludes our today's sessions, and we'll see you tomorrow, inshallah, at 8:30. If you come before 8:30, it would be much better. See you tomorrow. Thank you very much.